bilateral wheezes. He was maintaining saturation with oxygen support. ABG initially was only suggestive of mild respiratory acidosis. So we started on the conventional treatment like your bronchodilators, steroids, and we keep the patient, but patient's acidosis started worsening. So we keep the patient on HFNC, but still the acidosis not improved. We intubated, put him on a mechanical ventilation. Still in a mechanical ventilation, in a paralyzed state, carbon dioxide was rising. So ketamine infusion was given, aminophylline was given, inhalational agent SIVO was given. Dr. J.C. Pandey sir is here, is kind enough to provide that machine. Go ahead with the sevoflurane, but all failed. And again go ahead with the sevoflurane, but all failed. And again pH came down to 6.9 and carbon dioxide 126. Now question arises in every mind, what next? What we will do? The similar situation in a case scenario 2 is a young male admitted through cardiology in the city-based department, and he was having young male with history of acute febrile illness, admitted with the low perfusion state. Echo was suggestive of global hypokinesia and myocarditis. USG lung done, suggestive of fluid overload. We are trying to rise the MAP, but still with the multiple inotrope and vasopressor, MAP is around 50. Serial ABG was done, suggestive of persistent high lactate. Now question arises because a young male, 25-year male, what next? And similar scenario in case 3 still sees on a VV ECMO. The young lady with a history of fever of 3 days, shifted from the one reputed hospital of Patna, intubated on ventilator. Her ABG was a PF ratio less than 100. In fact, I written 150. Chest X-ray bilateral whiteout lung. POCUS suggestive of good LV function. Prone ventilation tried. Still P-plat remains very high. PF ratio is not improving. Now question again arises, what? We are not going to ventilate this lady. So in all 3 cases, what the clinician, what the intensivist wants, we want to buy some time. We know bronchospasm will relieve in a 2 or 3 days. We know myocarditis will resolve with the time. We know the lung inflammation will subside and oxygenation improve. It's just a matter of a time. So how we are going to take this time? The answer is in extracorporeal treatment. That's why last 10-15 years we are talking regularly about the ECMO. So many times we are saying young patients are dying without this. We know that 2-3 days, more days, or patient will not go in a organ failure. We could survive this. The lady could survive this kind of situation. And answer definitely in the extracorporeal treatment. In a case 1, we did the ECOR. This is extracorporeal carbon dioxide removal. In case 2, we did VA ECMO. Dr. Rajiv has shared the video of that patient of VA ECMO. In third case, we are going the VV ECMO, that is veno-venous extracorporeal membrane oxygenation. In a small, we understand by the ECMO. We know is the extracorporeal treatment. So extracorporeally, that means outside the body. Outside of the body, what we are doing? We are maintaining the circulation and we are also maintaining the gaseous exchange. So circulation, so give the rest to the heart, oxygenation to give the rest to the lung, and we are providing through this support. This is a temporary life support, as Dr. Ajay sir has told, and this is for the reversible pulmonary or in a case of cardiac failure. So what is the goal of ECMO? In our last picture, I'll show one more thing. See that the one is in a VA ECMO or VV ECMO, what we are doing, there is a one cannula in a VV ECMO, both in a venous. One is in a femoral vein, another in a jugular vein. One is for the drainage, another is for the input. So we are taking out the venous blood through the pump, that going to the membrane oxygenator, and there is a swipe airflow that helpful in washing out the carbon dioxide, and the oxygenated blood will return back to the heart. This is the entire circuit of any kind of ECMO. If it is in the aorta or artery, it is called the VA ECMO. If it is in both in a venous, it is called VV ECMO. So, what is the goal of ECMO? To ensure the tissue that have enough oxygen. So, we are worried about the perfusion. ECMO does not heal the heart or lung, but gives the time to rest and recover. Give lung rest. Able to decrease other drugs that support the heart, like anatropes, vasopressor. ECMO serves as a bridging therapy, not a curative therapy. It gives us a time to save the life. Use as a bridge to recovery, buying time for patient to recover. Bridge to decision, provide temporary support to patient and allow clinician to decide on the next step. Bridge to transplant, provide support to the patient while awaiting suitable donor organs. Patients are going for any lung transplant or heart transplant. So types of ECMO, one is a VA ECMO, that is veno-arterial ECMO. The drainage cannula is of venous and return cannula in the artery. To support heart and hemodynamics, give both cardiac and respiratory support. That is for the cardiogenic shock. The patient is having the cardiogenic shock. We are using this VA ECMO. VV ECMO basically for the respiratory support. Drainage cannula and return cannula both are in the venous. Gives only respiratory support, particularly cases of ARDS. And rest indication my panelists will discuss, like eCPR, role of eCPR and various indication. The Dr. Prabhat is here to discuss about all. So another type of ECMO is extracorporeal system is ECOR, that is extracorporeal carbon dioxide removal. This is a technique of partial respiratory support that achieve removal of carbon dioxide from blood through a low flow extracorporeal circuit without significant effect on a blood oxygenation. So in the low flow, basically what we are doing VA ECMO, the flow is very, very high. Here we are using the flow is, we are keeping the flow is very high. But in a ECOR, we are using the flow is low, up to 300 to 400 ml of the blood per minute. And we are using the swipe gas flow that will helpful in washing out the carbon dioxide. So we don't have a dedicated ECOR right now in our Bihar. So we use this hemodialysis machine. In this hemodialysis machine, there is a pump. We use the swipe gas that will helpful in washing out the carbon dioxide, and we use the pediatric oxygenator that will helpful in oxygenation. And with the successful outcome of this ECOR, we celebrated. Our respiratory team, Dr. Vijay is in the picture, our critical care, Dr. Prabhat and entire team is with us, and the patient went home and he was happy. This is again an era of starting the respiratory dialysis. In the future, we can think about if the patient is coming with a higher carbon dioxide level, they don't want, they are on a non-invasive support at home, they may come like a hemodialysis for removal of carbon dioxides. Okay. Thank you. Thank you for my presentation. So, mic to the doctor.
Hello.
Yes, sir.
Now, thank you, Dr. Kishore. You elaborated the use of ECMO in such a nice way. And this is a newer thing for the Bihar. We are sending patient, as Ajay told us, always on outer side. Especially this ECMO use is very much popular during COVID period. We are sent so many patients to the Hyderabad and other places. Now that we are fortunate with this institution, we have a ECMO and ECOR, and we are using it very successfully. And the peoples of Bihar should be fortunate to get this facility in Patna, instead of going so much of air ambulance cost, and all the things are cut down to this only place in Patna. So peripheral people should send such type of patients to our institute as early as possible to get benefited by the ambulance or whatever things. And the indications and something related to the ECMO, may the panelists should ask a few questions. Indications for the ECMO, Dr. Prabhat, can you tell us the BB ECMO indications, decision making? points, few points you can share.
VV ECMO indicated mostly in cases with acute reversible life-threatening condition, and most common reason being pneumonia, viral, maybe due to viral or bacterial. Second is maybe due to aspiration or other etiology, and different criteria is there. One is Moody scoring. Moody scoring more than equal to 3. It donates severe ARDS. And it has 4 components. One is PF ratio, other is chest X-ray, and third one is PEEP and compliance. And depending on the scoring, we can consider for ECMO. Then second one is ELSO criteria. In this, PF ratio is less than 80. We started with conventional optimal ventilatory setting and give prone ventilation also, and if patient is not improving, then we can go for ECMO. Then third one is EOLIA criteria. It is almost same as also. In this, we can even think of starting ECMO after proning the patient for 3 hours, and if PF ratio is less than 50, then we can consider for ECMO. And another one is hypercapnic respiratory failure. Even after optimal ventilatory setting, in that scenario also we consider for ECMO. So especially in severe ARDS cases, if PF ratio is less than 100, we started with optimal ventilatory setting. Then second thing is to try proning the patient, and if patient is not improved even after 6 hours, then we started with ECMO support. Yes, sir.
And now another thing we have to
One
ask
thing
with
I
you.
want to add, sir, for bridge to, as Dr. Kishore already said, for bridge to transplant, when we are waiting for transplant, we can use VV ECMO for and waiting for transplant. In those cases, we can use VV ECMO also.
Yeah, very good. And another thing, the people have doubt about the when the veno-arterial ECMO is required. What is the decision-making point for the veno-arterial?
Sir, in those refractory cardiogenic shock, those who are not responsive to the conventional pharmacological management and fluid therapy, in those cases, we consider VA ECMO. And in other cases, when we are waiting for cardiac transplantation and bridge to transplant, or we are waiting for left ventricular assist device, in those cases, we can apply VA ECMO.
Now, one thing we are facing day to day in the our critical care area, that we are facing so many of the patients with the septic shock and reduced peripheral perfusion, and that is refractive. In that case, what is the role of ECMO in the septic shock?
Sir, ECMO is not a very good choice in case of septic shock, but there are few conditions where we can consider ECMO. First is because in sepsis there is hyperdynamic circulations and the vasoplasia, and I think ECMO doesn't take care of vasoplasia. The problem is that. So there are few conditions where we consider ECMO, like in those septic shock where there is a cardiac involvement, that is cardiogenic shock, where we can apply VA ECMO. In second is when the ARDS sepsis with the ARDS, where hemodynamic instability is not that much, so where we can use VV ECMO. And the third part is in case of there is a vasoplasia, there is a venous arterial venous ECMO, there is central ECMO is considered as a triad. So these are the conditions where we can use ECMO in septic shock.
Now, in this scenario, we are using at present with ARDS already patient is on ECMO.
We are using VV
In this situation.
I have a question to Dr. Kishore. You're very right. VV is for the respiratory problem and VA for the cardiac problem.
Yeah.
When we think that the patient is going to survive, there is some reversible factor and everything has failed, then we will put on this because this is a costly. So first thing I want to know from you, how many days you have put on patient on ECOR to get success? Number one, what was the cost? And in COVID period, we have sent few patients for ECMO and none survived. So what was the reason?
So, there are the multiple reasons. As Dr. Samshad in a lecture, he raised the question कि when you are using like a parachute, you know when to open, and we know the time to open and when time to land. So it's very important the initiation. If there is a shock, if there is a multi-organ failure already started, in that scenario, if you use the ECMO, definitely is going to fail. Probably in COVID time, there is a delay, resources are limited, and we are keeping the patient very late in a ECMO. That's why the less survival could be the one reason. Second question is about the cost of the ECOR. The cost of ECOR, what?
The cost for the patient.
Cost
But how
of-
many days you have kept patient on ECOR when you get the success, and what was the duration of his stay and what was the cost?
Yes, sir. The cost for the, matlab, just I am coming for the ECOR. ECOR cost, what we use the pediatric membrane, that is coming around 16 to 18,000 rupees. And we use the dialysis cannula. So dialysis cannula, normal dialysis cannula is hardly 4 or 5,000 rupees. That's all our cost in this. And the one circuit is of around 8 or 10,000. That's all the cost is. And rather the hospital course, staying course, medicine, antibiotic, these are extras. So ECOR is not that expensive. But definitely ECMO is a little. But at the cost of the life is very important, sir.
Your second patient was on cardiogenic shock, I think, so, or myocarditis.
Yes, sir.
Or heart failure.
Yes, sir.
So how many days you have put on
4
ECMO?
days.
4 days.
4 days.
One role about post CPR. When a patient goes arrested, we are doing CPR. After that, for the sometime patient's hemodynamic instability in that period, and that needs support. That is eCPR. Yes. What we can do in that way, support the life of the patient for that period?
Sir, it's emergency initiation of extracorporeal life support during refractory cardiac arrest patient, and in this few criteria should be present, like initial initiation of good quality of CPR within first 10 minutes, initial rhythm should be VT-VF, and the etiology should be reversible. Then we can consider for eCPR. In this scenario, simultaneously cannulation with CPR continues side by side, and after putting on ECMO, we see for LV distensibility and other factor, and find out the etiology and treat the cause.
And one thing with the Bihar, it is there are so many challenges in getting the finances and consumables for the Bihar. Then you can tell us some prospect challenges for Bihar.
My last question to you is, time is up. So is your everything is backed by randomized control trial or not?
So many trials are there, sir. So many, numerous trials on that. That's why ESLO is there, sir. ESLO is a registry for what they are doing the worldwide. They are maintaining that registry, and there are lots and lots of entry on that.
Around 24,000 cases was done as per ELSO criteria.
So thank you, Dr. Kishore Jhunjhunwala, for this topic. This is, for most of us, it is the initiation of a life-saving support, and as it is done by the panelists, that we have to get ourselves accustomed that what are the conditions. The first thing he told that it should be recoverable or reversible, because we cannot put something on support where it is going to be indefinite period, because the cost is very, very high. So naturally this has to be, but still it should be recoverable, and we have to give every chance that whether the patient should be kept on ECMO, and we all practitioners should train ourselves, and that's what for these kind of CMEs is required, so that more and more data is available. And in our place also at AIIMS Patna, we have got an ECMO machine, and till now we have put only on 2 patients, because yes, the cost is one very important factor. Another is time at which the ECMO should be started, where we should start. It should not be started as a last resort, but it should be incorporated into a continuum of treatment, rather than like we do in ventilator and other things. So naturally, if the referral is done in the right time, the reversal or use of that machine will be of more importance. Thank you very much for giving me this opportunity to be here.
Thank you, sir. Thank you all the chairpersons and speaker. So we'll carry on with the next session now. I'll request chairpersons to come here. The next session is by Dr. Saket Sharma, role of endobronchial ultrasound in evaluation of mediastinal adenopathy. I request Dr. Sanjay Kumar, senior chest physician, to come here as chairperson. Dr. Sudhir Kumar, senior chest specialist, director of Ramakrishna Hospital. So please come on the dais. Dr. P.K. Agrawal, sir, head of department TB and chest, PMCH Hospital. Dr. Ravindra Kumar Sinha, sir, chest specialist from Chetna Clinic. Dr. S.K. Madhukar, sir, internal medicine specialist, Patna. All the chairpersons, please take the dais. I'd request our chairperson to please introduce the speaker.
So very good afternoon. Now we are going to listen about EBUS. In fact, EBUS is a modality which is being used for the past several years, but it was not available at our place. Recently, EBUS is being now available at Patna also, at AIMS and of course at Medanta. So we should know when to do EBUS and for what do EBUS. Saket will be discussing about mediastinal lymph adenopathy assessment through EBUS. He is senior consultant pulmonary medicine in Jayaprabha Medanta Super Specialty Hospital. He has completed his MD from IMS BHU and DM pulmonary and critical care from SGHVMMC New Delhi. He specializes in treating obstructive disease, pleural disorders, etc. He specializes in treatment of all kinds of pulmonary diseases. He performs various interventional procedures such as bronchoscopy, EBUS, thoracoscopy, etc. So I hand over the mic to Saket for his deliberations.
Thank you, sir. Thank you for kind introduction. Good afternoon to everyone. I will be talking about EBUS TBNA. So far, I mean, it's been there in practice since last 15 years, but for some various reasons we never had this, and just now we have procured EBUS scope in Medanta. So I will discuss about what is EBUS, where we are going to use this, and whatever we have done some 4 or 5 cases so far via EBUS TBNA, and I will tell about those cases. So bronchoscopy, that white light bronchoscopy is an essential diagnostic tool in the management of pulmonary pathology. It allows us to inspect the tracheobronchial tree, and with white light bronchoscopy we can do a lot of things what we have been doing since past various years. We never had EBUS so far, but even with bronchoscopy we can perform endobronchial biopsy, transbronchial lung biopsy, we can do bronchoalveolar lavage, and we can do conventional TBNA. Now, I mean, it's a very, very strong tool, and we have diagnosed more than 300 lung cancer in past 6 years. So it's a very important tool, but it has got some limitation. And the most important limitation is that we can't see what is beyond the tracheobronchial tree. We can see what is inside the tracheobronchial lumen. If there is a growth, there is any abnormality, we can sample that. But what is beyond the wall, we are not able to see. We have CT scan, and with CT scan, we have idea about mediastinal lymph nodes, if at all it's there, and we can perform conventional TBNA at few locations, most importantly at subcarinal location and 4R, that is right paratracheal location, but yield varies. I mean, my own experience with subcarinal TBNA is that yield is around 40 to 50%, and at right paratracheal, it's even lower. It's around 20-25%. The problem with that is that we have these anatomical landmarks that where we're going to puncture the, going to go for the node, but we don't know precisely where, if the needle is actually hitting the node. And this is what EBUS is going to address. We can perform this transbronchial nodal aspiration under ultrasonic vision. So that's how the linear EBUS probe would look like. It has got a transducer at the tip. And this transducer has got frequency of 7.5 megahertz. And since there is a transducer at the tip, so optics of EBUS is not end-on, unlike white light bronchoscopy. It is slightly angulated at 30 degree. And then we have got a dedicated working channel through which needle will come out at the angle, and it helps us penetrate the tracheal wall more easily compared to conventional TBNA. So outer diameter of this bronchoscope tip is around 6.9 millimeter. We have got 2 millimeter working channel, and as I told earlier, optics it's not an end-on view, so it takes some time to get used to this bronchoscope because you are not seeing things end-on. It's slightly angulated at 30 degree, and then we have got a disposable needle of various gauze. Most commonly used is 22, 21. And usually the scanning field is parallel to the incisor direction. It gives us around 50 degree of ultrasonic vision, what is lying beyond the tracheal wall. And for that we have to do a proper opposition to the tracheal wall. And it also has Doppler capability. If at all we are slightly confused that whether it's a node or it's a vessel, we can use Doppler imaging and we can get some idea about if it's actually a solid node, or if node is very vascular, and we can avoid hitting vessels using this Doppler capability. Now EBUS TBNA is a very important tool is cancer staging, because nodal status is very important in cancer staging, and it has been shown that EBUS TBNA has got far more higher sensitivity and specificity when it comes to nodal staging. When we don't have, when we did not have PET scan, we used to do CT scanning, and anything beyond 1 centimeter we used to consider it's a malignant node, and we used to stage like this. Then we got PET scan, and we can see what is the SUV max, whether nodes are letting up, and accordingly we can say whether this node is malignant or not. But even PET scan has got a poor sensitivity and specificity compared to EBUS TBNA, and it says that specificity is around 70%. That means 3 out of 2 will be true positive and 1 will be false positive. And what we are going to do, we are going to upstage the patient, and we may deny him a curative treatment. We will talk about that later, but EBUS FNA has got much more higher sensitivity and specificity. So these are the mediastinal lymph node stations. We have got 14 stations, and with EBUS we will be able to sample station 2, 4, 7, that is subcarinal, most commonly sampled station. Then station 10, that is hilar, and 11, which is interlobar. So 2, 4, 7, 10 and 11 are the stations we can sample. We also have this modality known as EUS, which few centers in Patna already have EUS. So if we combine EBUS and EUS together, then we can also sample the lymph nodes which are along the pulmonary ligament and paraesophageal. So when we combine these two modalities together, we can sample most of the lymph nodes. So these are the anatomical landmarks and details. I think I can skip these slides. So in order to summarize, EBUS has got very high diagnostic yield when it comes to the sampling of mediastinal lymph node. It's a procedure of choice for staging lung cancer. Again, for, when you want to be sure whether it's a TV, sarcoid, lymphoma, probably EBUS is a better modality than conventional TBNA. So with this introduction, we have procured this scope just 2 weeks back, and we did our first case on 30th of March, and in the last 15 days we have done 4 cases. And I will just give a brief summary of what we have done so far and whether this modality is useful or not. So this is the case number 1, 65-year-old male, post-CABG patient, presented in neurology with multiple ring-enhancing lesion in the brain. Following discussion with radiologists, they said it could be tuberculoma, it could be metastatic deposits in the brain. We don't know. So evaluation of, CT scan of lungs was done, and it showed subtle interstitial opacity in the lung parenchyma, and there was a large right paratracheal lymph node. And subsequently they referred us whether we could sample the lymph node and come to a diagnosis. Radiologist gave us differential diagnosis of tuberculosis and metastatic deposit. It could be either of those two things. So EBUS TVNA was done under GA via laryngeal masked airway, and we made the diagnosis of adenocarcinoma by evening, and patient was discharged by evening as well, and procedure was totally uneventful. And these are the images. If you go, you can see we have got a beautiful ring enhancing lesion in the left frontal area, and there were multiple metastatic deposits in the brain, and then we have got a pretty large right paratracheal lymph node at station 4R. And these were the CT scan. I mean, lung had few subtle opacities. It's a interstitial opacity, so we also thought whether it could be sarcoid, but all this confusion was resolved in a day. We were able to sample the node, and we got diagnosis by the evening. In fact, there is a modality known as rapid on-site examination, where cytopathologists sit in the bronchoscopy suite itself, and as we are sampling, they will go to see the sample, and they can tell whether it's a malignant, whether we have got granuloma or not, and we can make the diagnosis on the site itself. So very useful modality. Second case, 35-year-old male presented with fever and loss of weight. CT thorax was suggestive of intestinal adenopathy, and we had a very large lymph node at subcranial station. There was no evidence of necrosis, and there was no parenchymal involvement. Radiologist gave us differential diagnosis of tuberculosis versus sarcoid. It was referred by a senior physician. This patient, for some reason, he refused. I mean, this was the ideal candidate. This patient was the ideal candidate for conventional TBNA. We could have done a conventional TBNA for this patient, but this guy refused that I don't want to undergo procedure while I'm awake. So please do a EBUS TBNA where we are sure that you get the lymph node and I don't have to experience the pain, discomfort. I mean, otherwise bronchoscopy is a painless procedure. So with this, we evaluated. His MANTU was positive, serum ACE was high, and we did the EBUS TBNA at station 7. And cytopathologist gave the diagnosis of necrotizing granuloma, and once again patient was discharged on the same day. These are the images. So you can see the needle. This is the lymph node, and you can see the needle very nicely. And I think we have got a short video. This is a CT scan where patient has got a large subcarinal lymph node and needle piercing the lymph node. I think we have got videos missing. I mean, please give me 2 more minutes. So you can see needle piercing under vision. So we are very, very sure that we are in the lymph node and we are sampling the right tissue, and we are not hitting anywhere else. So third case, a 40-year-old female presented with prolonged cough, no other constitutional symptoms, CT thorax suggestive of reticulonodular infiltrate in the upper lobe, mostly in the upper lobe, with mediastinal and hilar lymphadenopathy. Bronchoscopy, white light bronchoscopy showed that patient has got mucosal irregularity, what we call cobble storing of mucosa, and she also had mediastinal and hilar lymph node. EBUS TBNA was done at station 7, and we also did endobronchial biopsy because we were seeing the mucosal abnormality. And in this case, what happened, despite localizing the lymph node and piercing it right way, we could not get the granuloma. But endobronchial biopsy gave us the diagnosis that patient does have non-necrotizing granuloma. So what was here, not every time you get, I mean, despite sample being adequate, the node was negative. But when we combine different modality, like endobronchial biopsy, transbronchial biopsy, we get the diagnosis. And diagnosis of sarcoid was confirmed, and patient was discharged by evening. So, I mean, this picture is not very good, but you can see that mucosa is slightly edematous. And in this, we cannot appreciate the cobble stoning, but video it was much more obvious. And the last case, this is not a case regarding EBUS TBNA, but it's a very interesting case. We rarely see and make these kind of diagnoses here, and I was very excited to present this one. So 45-year-old male presented with dimness vision in the right eye, and this guy's vision in right eye was reduced to hand movement. And patient presented he was seen by an ophthalmologist, he referred to neurosurgery, and MRI was done, And MRI has a very, very unusual picture. So he had focal proliferation of meninges at various places. And at some places it was compressing the optic nerve, which led to the loss diminution of vision. So radiologists, neurosurgeons, they discussed with radiologists. Radiologists gave differential diagnosis of whether it could be tuberculosis, or sarcoidosis, or vaginous. And subsequently, the CT lung was done, and CT lung had, and CT, I'm going down. Why it's moving up down? Sorry. So this was the CT picture. Patient he did not have significant lymphadenopathy. He had multiple nodular infiltrate, more pronounced in the left upper lobe and left lingular lobe. And this patient, this was pre-EBUS era. We did an endobronchial biopsy and transbronchial biopsy from the left upper lobe and lingular lobe, and we were able to demonstrate the non-necrotizing granuloma. Since vision was threatened, so we gave steroid. We discussed with the neurosurgeons, Dr. Mukund sir, and we gave him steroid before performing the procedure. And by the time procedure was performed and we got the report, it took around 4 or 5 days. Patient vision has come back. Vision was restored to normal. And we did MRI just 3 or 4 days back after receiving 1 month of steroid. And patient, this focal meningeal proliferation has largely resolved. So it was very gratifying, and we rarely make a diagnosis of neurosarcoidosis. So very interesting case. So what next? So what next is that on Tuesday we have got a case which is suspected to have a cardiac sarcoidosis. We have never diagnosed a case of cardiac sarcoidosis. I have never diagnosed a case of cardiac sarcoidosis before. So if at all it turns out to be positive, it's going to be the first case of cardiac sarcoidosis. And it's going to be very, very exciting. And then we have got another case where we have got we are not sure whether it's a T2N2 lung cancer or T1N1 lung cancer. And our oncologist, they want us to sample the node so that we can make sure that we are not falsely upgrading the tumor, and this patient can have benefit of a curative surgery if it turns out to be T2N2 disease. So that's all I have to say today. It's a very exciting tool for evaluation of mediastinal lymph node. It will change the way we evaluate these nodes, and especially in oncology. It's going to help a lot in oncology practice, where we can define the nodal status more precisely, more objectively. Thank you very much. So.
Request you, sir, to have a quick discussion, whatever.
We will straightway go to the panel discussion, please. If anything is to be discussed by the panelist.
First of all, congratulations to Team Medanta for establishing this EBUS for the first time in Bihar. That's just a simple question. How safe is this EBUS procedure compared to routine bronchoscopy?
So
you take more time.
Endobronchial biopsies are much more riskier, or transbronchial biopsies are much more riskier compared to EBUS TBNA. In EBUS TBNA, I'm not worried about patient safety. Whenever I'm doing TBNA, I'm more worried about my scope safety. So it's very safe, sir. Whatever complication can happen because of sedation or GA, that's all. Otherwise, it's a very safe procedure, and we have discharged all patients of EBUS TBNA on the same day. So
that's it.
All patients should go under the GA?
So right now, sir, we have just started, and we don't want to have a non-diagnostic bronchoscopy. So we are doing under GA via LMA, sir. But as we gain experience, I'm sure after 10, 12, 15 cases, in suitable cases, patients, I will like to do under GA with bite block, sir.
How much cost for general public?
It's around 20,000 rupee when we are doing under LA, and 28,000 rupee when we are doing under GA, sir. But considering the cost of a scope, sir, which is almost like 80 lakh rupee, I think it's well justified, unless and until the government sector procures it.
Thank you. Thank you. Is there any question from the audience side, please?
We'll take a question after the lecture.
Okay, fine. So we can conclude the session.
Please be here.
Yep.
Please be
here for the next session.
Sir.
Due to paucity of time, we'll take questions at the end of the session. Now, I'd like to invite Dr. Randeep Guleria, sir, for his next talk. Sir is chairman of the Institute of Internal Medicine and Respiratory and Sleep Medicine in Medanta, Gurgaon. And I would like to invite Dr. Ajay, sir, as a chairperson.
It's a pleasure to have Dr. Randeep Guleria.
Thank you.
I don't know how many accolades he has already had. BC Rai National Award to Doctor of Science, Gaurav Puraskar, and so many things. He's the first DM in the country in pulmonary medicine. That's a credit. That's a accolade for him. And apart from being director of All India Institute of Medical Sciences, we have seen him in almost every program of COVID, in COVID eras. And he has been coolly answering all those questions. And I have got the privilege of your father's was my examiner in MBBS as well as in PGI days, my MD medicine examiner. So that is another, great.
Thank you.
So welcome, sir, and please go ahead with your talk.
Thank you very much for your kind words, and I shall basically be talking on sarcoidosis in Indian perspective. इसको कॉपी कर लो ना. Sorry for this glitch. So the challenges that we have in India as far as sarcoid is concerned, first of all, it was considered to be an uncommon disease. When I was doing my DM in PGI, we were told that sarcoidosis doesn't exist in India, and all patients who present with granulomas are tuberculosis and we should start them on ATT. I think that has changed a lot. And if you look at the registry, the ILD registry, which was published in the American Journal in 2016, and this is only looking at interstitial lung disease. We have stage 1 sarcoid which doesn't have ILD. You will find that almost 8% of cases who had ILD were diagnosed to have sarcoid. If you look at data from PGI Chandigarh, they in their registry almost 40% of patients had sarcoid as a diagnosis. So it varies from 8 to 40%, and if you start looking for it, you will pick up sarcoidosis, and it's not that uncommon a disease. Over the years, there have been changes that we have found in sarcoid as compared to the Western population in terms of the Lofgren syndrome, Herford syndrome being less common, and the fact that the female predominance may not be that much as far as India is concerned. We do see hypercalciuria and hypercalcemia in our patients. There have been a number of data which have been published over the years in small series, but I think it has basically become apparent that sarcoidosis is not that uncommon as far as India is concerned, and I think That is the first take-home message. That's not very uncommon. In 2001-2004, when we start looking at our series, we had almost 200 patients with sarcoid in that period, and we had 7 families. So it's a familial disease also. You can have families also who have sarcoidosis. The second important thing to remember is that it's a systemic disease. Sarcoidosis is not a disease as far as just the lung is concerned. It can have, we saw this case of neurosarcoid, you can have cases of sarcoid which can involve various organs. And therefore it's a disease which can involve a large number of organs. You have to examine your patient in detail to really pick up other areas of involvement. And I'll just give you some examples of this, the extrapulmonary involvement that sarcoid can have. It can have cutaneous involvement. These are nodular lesions that you see over scar, and these are some of our patients where you will find that the diagnosis of sarcoid could be made because of lesions seen on the scar. You can have erythema nodosum, which was thought to be uncommon, but if you look for it, you will find erythema nodosum. One of this is our staff nurse who presented only with persisting cough and had these lesions on her or ankle. You can have hyperpigmented or diffuse lesions which are scaly, and sometimes very important to examine the nape of the neck of your patients, because there also you can have lesions like that which can be a part of sarcoid. So if you start looking at the common manifestations of sarcoid as far as cutaneous manifestations are concerned, papules, plaques, nodules, alopecia, lichen planus, ulcerative lesion, annular lesions can also be a part of sarcoid, and that is something that we need to keep in mind, that this is also something that helps you in 2 ways. It also gives you a place from where you can take a biopsy, and if you are able to show non-gazetting granulomas with the classical picture, you can make a diagnosis of sarcoid. Ocular manifestation also happens around 15 to 28% of patients. Anterior uveitis, so remember to get a detailed eye examination of all your sarcoid patients, because here again you can pick up features which would suggest that there may be sarcoid involvement. It can involve the conjunctiva, lacrimal glands, and there can be corneal involvement. You can have orbital granulomas and optic nerve granulomas also. And again, if you look for it, you will find posterior segment involvement. But it's also important to keep in mind that other organs can be involved. I'll give you an example. This is a patient who was admitted. He's a 60-year-old patient, admitted in cardiology with the diagnosis of complete heart block, thought to be sclerodegenerative. 6 sinus syndrome, was admitted for a pacemaker. A routine chest X-ray was done which showed some degree of interstitial shadows, and actually I was called to just have a look at the patient because the X-ray didn't look good. His PFT actually showed a restrictive pattern, and we thought that he had sarcoid, and we talked to his son, who was a resident at that point in time. He was not willing for anything because his father had come all the way from Odisha only to get a pacemaker put. So he just had the pacemaker put and he went back. He subsequently had hemoptysis and shortness of breath. 1 year later, he had a consolidation. We did a bronchoscopy and a transbronchial lung biopsy which showed non-necrotizing granuloma, and a diagnosis of sarcoidosis was made, and he was put on steroids also. He's doing well. This is the X-ray of this patient, the CT, and you can see he has a pacemaker. But if you look at the CT of the patient, you can see the pacemaker wire, but what you can see is the extensive nodular shadows which classically tell you that this patient actually has cardiac sarcoid. And this is the consolidation that this patient had and the shadow that this patient had, which was suggestive of cardiac sarcoid. We subsequently have done a study of 100 patients of sarcoid who were asymptomatic, didn't complain of any cardiac problem, and when we did a cardiac MRI in them, almost 10% of them had features of cardiac sarcoid. So cardiac sarcoid is not that uncommon, more commonly reported from people in Japan, patients in Japan, but in our country also, if you start looking for it, you will pick it up. And we published this series of about 3 cases long time back on cardiac sarcoidosis in uncommon presentation. One of our patients actually presented with ventricular tachycardia. VTAC in the emergency had to be cardioverted, and subsequently on evaluation turned out to have sarcoidosis. So it is a systemic disease. The third challenge is there is no definite diagnostic test. You can't really say that this is definitely sarcoid. Even if you look at the American Thoracic Society definition, it says a compatible clinico-radiological finding, histological evidence of non-gazetting granulomas, and rule out other granulomatous diseases. It becomes a big challenge in our country because tuberculosis is the most common granulomatous disease that we see, and I'll just come to that this becomes a big challenge. We have the scatting criteria for classification of sarcoid, looking at stage 1, stage 2, stage 3, basically, but if you look at your CT, you may actually need to change your criteria, which was the X-ray criteria, from what you see on the CT scan. But in our data, what we found was that bilateral hyadenopathy, stage 1 sarcoid, occurred in around 32% of patients. Stage 2 sarcoid, where you had both hilar glands and interstitial involvement, occurred in around 44%. That was the common one. And then we had other involvement also. The CT suggests shows classical features. I think sometimes if you look at the CT, you can make a diagnosis of definitely that this patient has sarcoid. It shows reticular opacities, nodular and reticulonodular opacities, which are very classical. There are subpleural and there are also perilymphatic. So you see these type of shadows on the CT, you see these nodular shadows, which are very, very classical that this is a patient of sarcoid, and sometimes you can make a diagnosis that this is definitely sarcoid. I'll just give you a set of CT scans. The first patient on the top side left is a patient who came with a diagnosis of CA lung, a large neck mass which was seen, which was diagnosed as CA lung. But if you look at the other part of the lung, there are these fine nodular shadows which have a bronchovascular distribution. This patient had sarcoid. She came from Nainital. She just came now after COVID and after 2.5 years and is doing very well. The scan on the middle, this is another patient who presented basically with pleural effusion. You can see that there is evidence of pleural effusion. Now only 5 to 10% of patients with sarcoid will have pleural effusion. This patient actually had pleural effusion, had a thoracoscopy done. A thoracoscopic biopsy showed a granuloma. She was not responding to ATT, so she was diagnosed as MDR tuberculosis. But if you again look at the lung, you will find that the lung itself shows these nodularities, which are very classically suggestive of sarcoid. And this patient had a transbronchial lung biopsy, which showed non-gazetting granulomas and was suggestive of sarcoid. The other patients have also features of sarcoid, including collapse, alveolar shadows, and therefore it's important to keep in mind that very variable presentations can happen. But if you have peribronchovascular nodularity going around the fissures, around the hilum and subpleural nodules, please do think of sarcoid as a differential diagnosis. Bronchoscopy sometimes is normal, but very often it will show a granular cobblestone tracheobronchial tree, again very, very classical of sarcoid. When we looked at our patients long time back in 2001, we were able to make a diagnosis of sarcoidosis by doing just a transbronchial lung biopsy and an endobronchial biopsy in around 77% of our patients. 5 patients required a thoracoscopic wax biopsy, and we did a skin biopsy in 31 and were able to get a diagnosis. But now we have EBUS and ROSE available, and we published our data way back in 2014 where we looked at the utility of endobronchial ultrasounds, TBNA, in a tubercular endemic country. And here again, if you see that almost a large number of patients could be diagnosed based on endobronchial ultrasound, and this was a very useful test. We also subsequently looked at comparison of conventional transbronchial needle aspiration and an EBUS, and showed that if in sarcoidosis, if you do EBUS, if you do a TBNA, endobronchial biopsy and a transbronchial lung biopsy, and you have a rapid on-site evaluation, that you have a pathologist or someone who can look at your slides and say that you have sufficient material, the yield is as good as what one would get if you did an EBUS. We also tried to look at the utility of a PET scan. Can a PET scan help us in terms of looking at disease and also response to therapy? And we found that PET can really pick up a large number of lesions, and this is this PET scan of some of our patients, and you can see that there's a huge uptake not only in the lung but even in the periportal area and even in the inguinal nodes. The PET is showing that there is a diffuse disease rather than just a lung involvement. Another patient, and again what you can see is the uptake coming in the spleen also, in the portal area also, and the classical parahilar uptake and subcarinal nodes also showing an uptake. So sarcoid does show a lot of uptake in PET scan also, and helps you in deciding. And in these patients, in some of them we followed up and after 9 months did a repeat PET to see whether they had resolved or whether there was still disease activity, and PET can sometimes help you in making that diagnosis. But I think the biggest challenge that we have is tuberculosis or sarcoidosis in our country. How do we differentiate between the two? Tuberculosis and sarcoid are very similar. The granuloma is very, very similar, and there has been a lot of debate that sarcoid and tuberculosis are two sides of the same coin, because there are a lot of things that they have in common. The epidemiology, the molecular features, and a large number of other studies tend to suggest that. I'll just finish in a minute. This is the last set. I'll just give you one final case. This is a case who actually came from Bihar only, presented with fever and swelling over the right side of the chest. Fluctuant lump was present on the lateral side of the chest when I examined this patient in the OPD. I put in a needle there, got frank pus, sent it, and it was positive for AFB, started the patient on ATT, and it improved. This is the CT of this patient, and if you look at the lower part, you will see that there is this abscess which is present. There is a soft tissue shadow which is present, suggesting osteomyelitis of the rib. And here is the CT scan where you can see that there is rib destruction also. Retrospectively, I've always thought that there was some nodularity in the lung, but at that point in time, it was only tuberculosis. He also had subcarinal node. This patient went back. He was a bank manager, and he said he didn't get leave for 1 year. So he continued his ATT for 1 year, came after 1 year with a fresh CT scan, and was told by the radiologist that his picture had deteriorated. He had MDR tuberculosis, but there was no chest lump. That lump had totally disappeared. But he had dry cough and dyspnea. And when we looked at him, he had this CT scan which showed these classical nodular shadows, did a transbronchial lung biopsy, and it turned out to be sarcoidosis. So you can have TB and then followed by sarcoid also, and some people even use the term sarcotuberculosis. So differentiating between tuberculosis and sarcoidosis will remain a challenge. A few years ago, we did publish a paper which was basically trying to address this issue of how do you differentiate sarcoidosis in a tuberculosis endemic area, the challenges that we face as far as India is concerned. And this is something that we do face in day-to-day practice. Sometimes some things help you, that mild symptoms will favor sarcoidosis. Cough is usually dry. Hemoptysis is rare in sarcoid. Tuberculin test is usually negative. Almost 95% of our patients had negative MON2. And that's because sarcoid causes cutaneous energy. So you find that there is lymphopenia and cutaneous energy. If you have a strongly positive MON2, err towards tuberculosis rather than that of sarcoidosis. ACE level is elevated. Hypercalcemia and hypercalciuria is seen in sarcoid. Extrathoracic lymph nodes, usually supraclavicular lymph nodes, are relatively rare. The nodes are usually homogeneous, symmetrical. Cavitation and pleural involvement, like I said, is uncommon, and you have classical distribution as far as the lesion is concerned. So I'll just conclude by saying that sarcoidosis is not uncommon in our country anymore. We must suspect it much more. It can have a varied presentation from asymptomatic to life-threatening, can be involve any system, and therefore it's a multi-specialty disease. The event of HRCT, TBNA, EBUS have all increased the diagnostic yield and helped us to make a definite diagnosis. But in our country, it will always be a challenge differentiating sarcoid from tuberculosis. Like I said, MON2 is a good surrogate marker. Remember, all patients of sarcoidosis don't need to be treated. Majority of them will actually have a self-limiting disease, unless it's a life-threatening issue or there is major organ involvement. There is really, you can sometimes just give symptomatic treatment. And treatment is basically if there is impairment of quality of life or there is organ-threatening disease. So I'll stop here. Thank you very much for your patient listening.
Thank you very much, sir. Wonderful talk. I think you have covered the scenario very well. What time is your flight, sir?
I still have time.
We still have time?
Yes.
Still you have time. So, can we take up comments from Sudhir and then Sanjay?
Sir. Just regarding your one case where you showed that there was a, this rib osteomyelitis tubercular, and then that was AFB positive, and subsequently later on CT scan you showed nodular pattern and all, and that showed non-caseating granuloma over there. But I was just wondering, can it be tuberculosis? Because even non-caseating granuloma is also common in tuberculosis.
So
once we had a diagnosis of tuberculosis, and we also know that tuberculosis gets reactivated, and sometimes we have seen many patients when we have been treating, say, pulmonary tuberculosis, subsequently the patient develops after, say, 6 months or during the treatment, he develops at another site, and sometimes at a third site, sometimes after 1 year, sometimes after 6 months of stopping treatment. So in most of those cases, we assume that it is just reactivation of tuberculosis, and many times we get a diagnosis if it is extrathoracic lymph node or not. So here I was just wondering whether you went ahead with just steroid treatment and subsequently patient became all right, or whether you thought that you should give both. What was your take?
So this patient had already been on ATT for 1 year, and secondly, all the other lesions, the subcarinal node, the osteomyelitis has resolved. We found a non-caseating granuloma, and he had no other constitutional symptoms. And we just treated the patient with steroids, and he still comes for follow-up. Unfortunately, he's done well, but he has some degree of fibrosis in the lung as a part of residual sarcoid. So he has some degree of impaired lung function in terms of restrictive lung disease, but he responded dramatically to steroids.
Did
And
you
there
try
was
to
no
evaluate other lung, other organ involvement by extensively investigating for other possible parameters for sarcoid like eye and all that?
So all patients that we
Cardiac
see of
sarcoid.
sarcoid, we do a evaluation in terms of an eye examination. We look for hypercalcemia, hyperuricemia, for uveitis. We will do some degree of cardiac evaluation, basically only an ECG and echo. Although I said 10% of our patients had features of cardiac sarcoid, but we don't do more invasive investigation. And then do a detailed examination of the patient. This is the baseline screening test that we do. But if you have symptoms that your patient complains of palpitations or some degree of breathlessness which is out of proportion, a more detailed cardiac evaluation should be done.
Sir, very well explained the challenges of sarcoid. One more challenge I think is how to treat it, because cortisone, if given, may have some detrimental effects. So when to start and how to start?
So I cut that part of my presentation because I thought I would run out of time because I didn't have enough time. But there is a very nice paper guidelines which are published in the American Respiratory Journal on management of sarcoid. Classically, it would say that, like I said in this last part of my slide, that if you have significant life-threatening organ involvement or the patient is very symptomatic, fever, body aches, joint pains, or there is involvement of the lung in which there is restrictive lung disease, there is nodular involvement, cardiac sarcoid, or there is uveitis, then definitely steroids are indicated. The indication is to give low-dose steroids rather than high-dose steroids, and most patients respond to that. Some patients who will not respond, we tend to give methotrexate as a subsequent drug, and they actually have done well with that. Although the guidelines say that if a small percentage of patients don't respond to that, then you can give biologicals like infliximab or rituximab. But most of our patients, I would say 90 to 95% of patients respond to steroids. Many of them don't need treatment. So I think we should not rush to give steroids. Some data suggests that if you give asymptomatic patients steroids, chances of relapse are higher. And therefore, very often you get patients who get a chest X-ray done, it shows bilateral hilar adenopathy, they are asymptomatic. I've had patients who actually got through the IAS exam, and on a medical examination they were declared unfit because the chest X-ray showed bilateral hilar adenopathy and they were asymptomatic. So they just needed a certificate and a diagnosis of sarcoid, and on follow-up it became totally all right. So all sarcoid doesn't need to be treated.
Just to add that cardiac sarcoids are, we have seen a lot of patients who came with very bad scenarios. Like somebody was referred from Muzaffarpur, ACS, diagnosis of ACS, recurrent VT, on the way. He was driven to Patna, he was working in Paras Hospital. This guy was very difficult to control arrhythmia. Angiogram done, which was absolutely normal. Somehow the arrhythmia came under control, then referred to a better center. Then she went to Mumbai. And then finally, on imaging, diagnosis of cardiac sarcoid was confirmed. And to believe that after steroid, everything disappeared. And she was on very, very low dose of steroid and no arrhythmia, nothing on follow-up. And she was doing very well. Lost follow-up because he was probably well. Similarly, there is a big series by Narasimhan. You must be knowing.
Yes, yes.
Big series by Narasimhan, our own person from Hyderabad, on cardiac sarcoidosis causing various kind of cardiac arrhythmia. So that is one thing we must remember, that a very common, relatively uncommon disease, but common cause of arrhythmia if you look for it. As sir has already said that about 10% patients will have some kind of cardiac involvement. So thank you very much, sir. Any comments, sir?
So people have looked at ACE levels. The utility of ACE level is not that good. You can have some degree of lymphopenia also, but the diagnostic utility of both ACE levels, lymphopenia has not been found to be that good, and therefore most of the guidelines now don't really say that you should rely very much on markers, both in terms of diagnosing disease and seeing whether there is a response to treatment or not.
And regarding survival, sir, what is your, what do you say, what do you comment on survival?
So my own feeling is that by and large sarcoidosis is a very benign disease. We have patients now for more than 20 years who are doing very well, and I have one lady who every 4 years will get a CT scan done because she is so scared that the nodes may come back. But most patients do well. There is a small percentage of patients who will have what we call end-stage lung disease, will have stage 4 sarcoid with fibrosis, pulmonary arterial hypertension, but that's uncommon.
Yeah, across the globe there are so many senior stars, writers, poets who are sarcoidosis and they have lived almost normal life 30, 40 years. That's very important. So if there are no questions from any corner, we call thanks a lot, sir.
Thank you very much.
Thank you all.
Sir, please wait. We want to felicitate. So you have a flight. So I will request Dr. Ajay sir to felicitate Dr. Randeep Guleria sir. Sir, if you have 5 minutes, can you felicitate our chairpersons? Dr. Ajay Kumar Sinha, sir. Dr. Sanjay, sir. Dr. Sanjay. Dr. Sanjay. नहीं ये डॉक्टर संजय का है. सुधीर कुमार सर. Dr. Ajay Sinha, sir. Dr. Sudhir Kumar, sir. Our speakers, Dr. Saket, Dr. Kishore, Dr. P.K. Agrawal, sir. Dr. Ravindra Kumar Sinha.
The chairperson of the first session also, Dr. Ravinder Sinha, sir.
He's here only. Our speaker, Dr. Saket, sir. First speaker, Dr. Kishore Junjunwala. Chairpersons of first session, please join us. Dr. Numesh Badani, sir. Dr. J.C. Pandey, sir. Dr. Prabhat Kumar, sir. Dr. Ajay Sinha, sir, NMCH. Dr. Rajesh Roshan, sir. इसके बाद देना, इसके बाद आगे जाना. Dr. Rajesh Roshan, Mediversal. Thank you, sir. Thank you, Dr. Nibuleya, sir. Yeah. Thank you, sir. Okay. Can we all?
Thank you, sir.
अजय सर, सर यहीं पे अब वापस नहीं. Sorry, sir. Sorry, sir. Sorry, sir. We'll continue with the next session now. I'd like to invite our chairpersons for the same. Dr. Rajiv Ranjan, Senior Physician from Chhapra. Dr. R.P. Geru, sir, ex-professor TMH Hospital, Senior Anesthesiologist, and now is working in T.Y. Patil, Mumbai. Dr. Shamshad Alam, Consultant Cardiologist in Jayaprabha Medanta. And Dr. U.N. Thakur, sir, Senior Physician from Patna. So our next topic will be Lyme's disease, a rare entity in India. And I would request our chairperson to please introduce the speaker, Dr. Mrityunjay.
Good afternoon. So since morning we are going through all the new procedures, newer diagnosis. So
Yes.
again in the pipeline we are having a newer entity which is
next topic is an rare disease, Lyme's disease. That is not actually rare since our knowledge is less. So Our speaker of this topic is Mrityunjay Kumar. He is consultant Jayaprabha Medanta Super Speciality Hospital, Patna, and he is MD Medicine, CMC Ludhiana, Punjab, and is best ongoing president in Department of Nephrology and Pulmonology, and ex-assistant professor, Santosh Medical College, Ghaziabad, ex-AP, NSMCH, Bihta, Patna, and presently he is consultant physician in Medanta. So now, just start, please.
Thank you, sir. Thank you for introduction. So, sir has rightly said, like it is not now a rare entity in India. Yeah, fine. So, two or 3 years back, it was supposed to be one of the rare entity, as the incidence was not as much. But still, like over a period of year, we don't have a data for that. But as per the whatever data is available, it says like every year the incidence is increasing. So almost 3,000 to 5,000 cases are being diagnosed every year in India now, and that too mainly in the forest area and northeast states. So basically these are still being diagnosed in those areas. So now we have a case over here in Medanta. So I am going through the case which she presented in our emergency. Basically, she was 35 years old lady. She was from Bihar with no prior comorbidities. She presented in our hospital with a history of chest pain, shortness of breath, multiple joint pain, difficulty in walking, swelling of the left foot for 10 days. And for the same, she was admitted in Muzaffarpur hospital, where she was treated for 4 days. She improved and was discharged from there. But again she started having the features. 4 days after discharge, she again started having the similar features and was brought in our emergency. And with the similar features, on examination, she was restless. Her heart rate was 82 per minute with on monitor. Heart rate was irregular. She was tachypneic with respiratory rate of 28. Her saturation was 99 on room air. She had joint tenderness. She was mildly icteric with no lymphadenopathy, no clubbing, and no cyanosis. Her systemic examination revealed CVS she was having irregular heartbeat, and rest of the systemic examination was normal, other than the musculoskeletal system, in which she was having at some joints she was having tenderness also. Investigation wise, her hemoglobin was 13.4 with count was 3100 and platelet was normal. ESR was high, CRP was high. ECG was having AV dissociation. It was second degree AV Movitz type 1. Our cardiac enzymes was normal, TOPI was also normal, thyroid profile was also normal. Echo was done, there was no vegetation, and that was grossly normal. NT-CCP was also done, that was also normal. RA factor, IFA, all were done. Her urine routine was having pus cells 20 to 25, but that was not significant. She was not having any history of dysuria or increased frequency, though there were some few RBCs in the urine. Blood culture, urine culture, both were sent, that was negative, no growth was there. A typhus IgM was also sent, that was also negative. Leptospira was also negative, RK39 was also negative. Liver function test, so bilirubin was slightly on the higher side, 2.1 was the bilirubin with mild transaminitis with SGOT 67 and SGPT 96. Creatinine was, KFT wise, blood urea was 37 and creatinine was 1.9 with mild hyponatremia was there. Viral markers were also negative. So, in view of this ECG, a cardiology opinion was taken. Though she was having chest pain, thought to have like having pericarditis, ECG was having type 2 AV dissociation, second degree AV dissociation, and cardiology opinion is taken, and it was advised to continue the same treatment, and if required will go for TPI or PPI if required. So she was continued. She was continued on this conservative treatment. She was started on injection Septaxone, and the very next day we had that second degree AV block was converted into first degree AV block. So, for the pain, she was having severe joint pains. We asked for orthopedician opinion also for the pain and was advised for conservative treatment. But as she was improved, she was doing well. On the third day of hospitalization, she was discharged because she improved and was discharged on cefuroxime for 2 days more. In view of like she might be having some viral syndrome which we thought of, and she improved, so she was discharged. But after discharge, again she called us, like again she started having similar features. But this time when she landed, she had a rash. She said like I am having all the symptoms. Other than that, I am having a rash over the right lower limb. So that was rash, and for the same rash, we are not like finding out the cause for the rash. So we asked for dermatology opinion, and dermatologist said like could be erythema migrans. That was the hint given by the dermatologist. It could be, but because the lesion was not very classical, so they thought of, he said like it could be erythema migrans. So again, now we look into the literature. We find out patient who was previously not having any comorbidities, having second degree AV block, she was having chest pain, that could be pericarditis and erythema migrans. So we thought of the three things, and it turned out to be, the differentials came out to be a Lyme's disease. So to confirm it, we continued ceftriaxone. This time after admission, we continued ceftriaxone, and we sent Elijah for Borrelia burgdorferi. That we sent and we continued the medication. After 5th day of sending the investigation, we came to know like it is positive. So to confirm the diagnosis, we sent for Western blot also. The Western blot also came out to be positive. Patient was continued on the same treatment. 5th day, she was quite normal. She was quite she improved. Chest pain also settled down. Those palpitation part also settled down. Breathlessness was also settled down. She was not having fever, and so this thing ceftriaxone was now converted on oral doxycycline, and oral doxycycline was continued for 21 days. Patient became totally asymptomatic. She came on follow-up. She was asymptomatic. She was not having any residual disease. So, bit about the signs and symptoms of Borrelia burgdorferi. So, basically, it presents like a viral syndrome only. It presents like fatigue, fever, severe headache, anorexia, myalgia, arthralgia, neck stiffness. It can cause regional as well as local lymphadenopathy. Then erythema migrans, that is the characteristic of the disease, and cough, sore throat, iritis. So this is the same symptoms, which is the diagrammatic presentation of the symptoms. So this is basically Lyme's carditis, which is also a very rare entity. I mean, among the Lyme disease itself is a rare entity, but Lyme's carditis is definitely among the Lyme's manifestations. Lyme carditis is a rare entity. So in US, basically Lyme's carditis is caused by Borrelia burgdorferi. In Asia and Europe, it is caused by Borrelia abzeri. It occurs in early disseminated. Basically, it has three phases: early localized and disseminated. Early disseminated and late disseminated. So it presents in the early disseminated phase in 4 to 10% of untreated patients, and male predominance is more in case of Lyme carditis. So the features is like chest pain, palpitation, breathlessness, and syncope. And most common clinical sign of Lyme's carditis is AV conduction block, which is it can be first degree or second degree. So second degree both, it can be morbid type 1 and morbid type 2. So it can also cause decreased cardiac contractility, pericarditis, and early pancreatitis also. With in some of the cases, have you noticed that sudden cardiac death can also occur. So the treatment part, particularly I have limited for carditis only. Doxycycline 100 milligram BD for 14 to 21 days. Amoxicillin is alternative. Second alternative, cefuroxime 500 milligram BD for 14 to 21 days, and in severe cases like IV ceftriaxone can be given for 21 days. So this is the bookish classical presentation of erythema migrans. In our case, it was like not very clear. So this was a picture, and we are not very clear like whether it is erythema migrans only, but it was given a hint from the dermatologist like it could be, and then we proceeded to rule out Lyme's disease. So now patient is stable, she is doing well, and the guidelines, as per the Sanford guidelines, we have given the guidelines for all these like early cases, late disseminated cases. So this is the guidelines, the latest guidelines from 2022 Sanford. So that's it. Thank you.
Thank you, Dr. Mrityunjay. Actually, first of all, you have diagnosed this case on the basis of cardiological finding. Later on, RAS was detected. So why not it is a case of sarcoidosis? First of all, you have thought.
Sir, see, basically she presented thrice. Once she was admitted in Muzaffarpur, second time when she came over here, we partially treated the patient. There also she got partial treatment. In our hospital also she got partial treatment. Even on ceftriaxone, symptoms subsides. But here also we partially treated in view of like it could be a viral syndrome which has caused all these things. So we discharged. But third time when she presented over here, that time having erythema migrans, that was the classical skin manifestation which we got. With that she was having pericarditis, chest pain was there, and third like AV dissociation. These are the triad which is like diagnostic triad for erythema migrans. So we thought of, after reviewing the literature, we thought of it is erythema migrans, and that is like confirmed by the serology we sent, that came positive, and the second also Western blot also came out to be positive. So we thought of like
that's right. So what was the time spent before reaching to you, that patient?
So she was admitted 4 days in Muzaffarpur.
Yeah.
Here she was also admitted for 5 days. And third day she improved, so she was discharged. 2 days we continued cefuroxime, but again like 6 days after discharge from here, she started having similar symptoms.
Okay. So it was again it is acute case.
Sir, we cannot say it is acute case because see, even if this Exodus ricinus, which bites, which inoculate the Borrelia burgdorferi, sometimes people won't notice because small insects, even if it bites, nobody notices it. So generally manifestation of erythema migrans occurs, I mean sometimes it occurs, it takes 3 days to 21 days also. So that time they come to notice like the erythema migrans.
Thank you.
What is the role of local, what you call local analgesics or something like local antibiotics or something like that? Because wherever the site of infection is there, and plus systemic steroids in such a condition.
Sir, there is no role of systemic steroids, sir.
And beta stimulant, because he had a arrhythmia.
She has arrhythmia. So I asked, actually my cardiologist Dr. Samsad was there. He said, sir, that it looks like infective only, and the way ECG is showing, it is like it is spontaneous, it can revert spontaneously. So you better wait, you treat from your side, you find out the cause, and then sir, the very next day ECG from Morbid's type 1, it came to first degree heart block.
Yeah, actually when at the first instance when I saw this case, a 35-year young lady, ECG with AV dissociation, but the clinch was that the QRS was not that much wide. So whenever you get a narrow QRS AV dissociation, it means that there can be some reversible cause. Usually these patients do not require pacemaker. And the most important thing, she was not having any syncope or pre-syncope. The usual presentation was joint pain and fever. The first differential diagnosis in a young female usually is rheumatic carditis. Carditis in rheumatic fever. These cases usually present with carditis, joint pain, and they can also present with a conduction block. The second differential diagnosis was sarcoidosis, which we were having in our mind that this can be a presentation of sarcoidosis because erythema migrans can be seen in sarcoidosis also. But multi-system involvement was there in this case. Musculoskeletal symptoms were there, skin manifestations were there, cardiac manifestations were there, but there no pulmonary manifestation was there. So you can get a case of isolated cardiac sarcoidosis, but in disseminated cardiac sarcoidosis, pulmonary involvement is must. So it has to be there. Then we thought that no, we need to find out something different. So after Hunt in her second visit, we got that it is a case of Lyme's carditis. And Dr. Mrityunjay, and he was very much confused that whether she will need a pacing support or not. So as per the JAC guidelines which came out in 2019, it was clearly postulated that those patients of Lyme carditis, they usually never require a pacemaker. Whenever the inflammation phase subsides, the heart block reverts back to normal sinus rhythm. The same occurred with this patient also. So it was a great case. Thank you for that.
Thank you for a very nice presentation. And you have given us a lesson that in this scenario, we must keep in mind the Lyme's disease also.
Sir,
Thank you.
now it is thought to be like it was underdiagnosed entity. It is coming out. I mean, the cases are on the rising trend. So last year data showed like 3,000 to 5,000 cases has been diagnosed in India, which was like earlier supposed to be a very rare entity.
Yeah,
I think, thank
we
you.
can
Any
have
questions from the audience?
From audience also.
But this is something very rare disease.
Yeah,
Definitely, sir. Viral myocarditis, all the like viral entities can cause viral myocarditis and present
lot
like
many
this.
causes which we keep on seeing. They have some kind of conduction problem which reverse quickly. I mean, there is no treatment required. So those differential diagnoses should be kept.
Yes, sir.
Rather than confined.
So that is what we thought very first time, sir. We thought of like viral syndrome, and then we discharged her.
Also, geographical variation is there. Suppose that if the same patient, if I would have been there in South American or African region, then I would have also ruled out Chagas disease because trypanosomiasis is also a very common cause with this kind of presentation.
Chagas, babesiosis, allergiosis, like these are the differentials of this thing, Lyme's.
Thank you so much. Thanks
Thank
for
you,
the
sir.
good presentation.
Thank you so much, sir.
So we'll start the felicitation ceremony also. I'll request Dr. Ajay sir from NMCH to please felicitate our speaker, Dr. Mrityunjay. साथ में देना। Thank you, chairpersons. Now we'll start the. आपका होगा सर इसके बाद. Oh, so the printer is stuck a little bit. So the printer is stuck. Just 2 minutes. 2 minutes. Yes, sir. Thank you, sir. So we'll start the next session, which is on urology and nephrology. First, we'll go with the nephrology session, and I'd like to invite our chairpersons for the same. Dr. Om Kumar. Sir, Agya sir, most wanted. So I'd request Dr. Umesh Badani sir to please give the memento to Leo. Our chairperson for the session, Dr. R.P. Gedu sir.
Thank you, sir. You are doing good job.
Thank you, sir. Thank you, sir. Dr. Hemant Kumar, senior nephrologist from Patna. He's ex-HOD, IGIMS from nephrology department. Dr. Devendu Bhushan, sir, additional professor of medicine from AIMS. Dr. Kumar Anuj, DM endocrinologist, senior consultant from Patna. And Dr. Abhishek Chaudhary, sir. Please, everybody join the dais. Now we'll start the session with the talk of Dr. Suraj Gupta. The talk is on chronic kidney disease unmet need, and I would request our chairperson to please introduce our speaker.
Good afternoon, everybody, in this session of nephrology, and it is a very important and tricky topic, the unmet needs in chronic kidney disease. And to discuss this very important topic, we are having none other than Dr. Suraj Kumar Gupta, who is a senior consultant nephrology in Jayaprabha Medanta Super Specialty Hospital, Patna. He has completed his MBBS from prestigious Maulana Azad Medical College, Delhi. Then he did his MD from AIMS, New Delhi, followed by DM from one of the best centers for nephrology in the country, CMC Vellore. He has expertise in treating glomerular disease, peritoneal dialysis, hemodialysis, nephrotic syndrome, renal transplant, infectious kidney disease. And I have got personal experience of having his excellent nephrology practice in my clinical scenario, that I have come across many patients where he has made a excellent diagnosis, rare diagnosis. So I request Dr. Suraj Kumar Gupta to discuss. And just to introduce the subject, that we know that chronic kidney disease is very common, it is harmful, and most of the time it leads to end-stage renal disease when the patient requires renal replacement therapy. And most of the time we are not able to halt the progression of CKD to end-stage renal disease. Even with the advent of ACE or ARV 30 years back, there are still residual risk of developing this CKD patient into the end stage, and at the same time they are having highest degree of cardiovascular mortality. So, and the most important thing, even when we are having so many renoprotective drugs, the initiation of these drugs are still very less, almost in the tune of, like if we talk of ACE or ARV, it is in the tune of 16 to 17%. And more important, that the discontinuation of this ACE or ARV at the slightest of developing complication, these important renoprotective drugs are discontinued. So to discuss all these unmet needs, how to retard the progression, how to use this newer modality of renoprotection, and how to improve the outcome in renal replacement therapy, I request Dr. Suraj Gupta to deliver his lecture. Dr. Suraj.
Thank you, sir. Thank you for the kind introduction. I shall discuss this topic, chronic kidney disease unmet need. As sir already has highlighted, why are we talking about the unmet need? Because of the huge disease burden and our limitations in the aspect of the pharmacological therapy that we offer, our limitations in the aspect of retarding or preventing the progression of chronic kidney disease that we offer. That is why we are talking about the unmet need or limitations in chronic kidney disease treatment. Talking about the epidemiology of the chronic kidney disease, if we CKD over the last few decades has become a major burden, which is affecting globally, especially our country, which is becoming the diabetes capital of the world. Right now, if we talk about the prevalence of chronic kidney disease, it extends from around 7% to 8% to almost 17 to 20%. Globally, if we talk about 2.6 million patients are there on dialysis, almost 1.2 to 1.5 million patients die because of chronic kidney disease or related complications, and it's almost the 12th leading cause of death globally worldwide. What is driving the number of increase in chronic kidney disease? Obviously aging, as well as increasing prevalence of lifestyle disorder, that is diabetes and hypertension. If we talk about the economic burden, globally almost 2 to 3% of the annual healthcare budget goes on the treatment of ESRD, that is dialysis. So we need to understand the economic as well as the morbidity and mortality burden that is causing that is because of the chronic kidney disease. Talking about the prevalence, this was a study conducted by ISN Disease Control Data Center, which was published in 2016. It was conducted in 8 low to middle income countries. It showed almost a very high prevalence, especially in the high risk population, almost to the tune of 36%. High risk population was defined as patients who had diabetes, who had hypertension, or who had cardiovascular disease. So having a 36% population of the high risk population suffering from chronic kidney disease is huge. And what they found was that almost this 36% included both patients with a GFR of more than 60 ml per minute also, that is CKD 1 to 2. So when they included patients only with CKD 3 to 5, that is GFR less than 60 and with microalbuminuria more than 30 milligram, that was even then the risk came to around 14% of the total high risk population. That is a huge population. If we talk about in our practice, diabetes and hypertension, cardiovascular diseases have increased dramatically. So having a 14% prevalence in that population makes it a huge disease burden that we need to keep in our mind. In India, obviously there are multiple factors: poverty, poor sanitation, high water contamination with heavy metals, increasing lifestyle disorders, that is diabetes and hypertension. All these contribute to very high risk of chronic kidney disease. But the most agonizing and difficult thing is that almost 50% of the patients that come to that are first time when they get aware of the presence of chronic kidney disease, their GFR has already fallen to less than 15 ml, or they have already reached the stage of ESRD. The other most difficult part is that majority of the patients who reach ESRD, almost 90% of them drop out of the treatment program because of the lack of funds. So only 10% of the patients who reach ESRD per year do get some form of treatment, either dialysis or transplant. That is the most agonizing aspect of chronic kidney disease. So it does make our job very difficult, and it does make our job huge in terms of that. If we talk about the mortality data in over the years, what we can notice is that except for chronic kidney disease, rest everything else has shown significant decline in mortality. Ischemic heart disease, stroke, COPD, everything, the age-adjusted mortality rate has declined significantly compared to chronic kidney disease. The mortality has remained almost same. If we consider the data of patients on dialysis, the patients on dialysis have over the year last decade have shown almost a rise of 7 to 8% per year. The number of patients have grown, and almost now in India almost 1.2 to 1.3 lakh, 1.5 lakh patients are there on dialysis. If we see the European countries, they are overall the data of patients on dialysis, the growth is not that much compared to Asian countries, the lower to middle income group countries. So that, especially if we talk about Southeast Asia, especially the lower middle income group countries, so India is in a very disadvantaged position. So it does make our job significantly important. That is what the risk of morbidity and mortality rises sharply, almost 10 to 15 times from CKD stage 1 to 2 compared to CKD stage 1 to CKD 5. Also the hospitalization rates, the cardiovascular event rates, the mortality almost 15 times rise from the CKD 1. That is the burden that we are talking about. Majority of the mortality that we deal with in advanced stages of CKD are compared to early stages. Early stages we see mostly malignancy and other etiologies. In advanced stages cardiovascular mortality increases, but what we do find in patients with advanced chronic kidney disease is the majority of the mortality related to cardiovascular is non-atherosclerotic, which becomes even more difficult to treat because it becomes less preventable compared to atherosclerotic cardiovascular diseases. This was a paper. So the most difficult thing that we find is the majority of the focus of overall physician community, the medical community has been till now is on dialysis, how to manage patients on dialysis, how to do transplants. This was a paper in 2000 by Dr. Brian Pereira in Nephrology Frontiers, Nephrology Forum. This was, here he had discussed about the optimization of pre-ESRD care to optimize the outcomes of patients who reach CKD5 or dialysis. This is the paradigm which he had offered, and indices of quality CKD care. One of the most important aspects would be the interventions that delay progression. See, once the patient, any patient who reaches 2 or 3 creatinine would eventually progress. But what a nephrologist or a physician can offer is to delay the progression of the chronic kidney disease. If somebody reaches CKD5 at 2 to 3 years and somebody reaches CKD5 at 10 to 12 years, that is the difference that we can make if we can offer a good form of treatment to them. So ARBs and ACE inhibitors and SGLT2 inhibitors is what we can do. Good blood pressure control, good blood sugar control has also should be done. One of the most important things that we keep talking about is protein restriction. I'll talk about it once more. What other thing that we need to do is prevention of uremic complications, malnutrition, anemia, acidosis, osteodystrophy, modification of comorbidity, that is cardiac disease, vascular disease, neuropathy, retinopathy, all these things should be treated. If we are finding that the patient is eventually now going to land up with RRT, the preparation for RRT, the timely counseling for either dialysis or transplant, assessing the patient for suitability of transplant, and creating a vascular access, that is AV fistula. Role of combined ARBs and SGLT2 inhibitors, if we see if anybody starting at an age of 55 years is this was a paper published in CJASN in 2022, they statistically analyzed that if somebody at the age of 55 is offered ACE inhibitor, ARB plus SGLT2 inhibitors, and the mean creatinine which was of the sample was around 2, so it was around 40 ml GFR. So it was a fairly advanced chronic kidney disease, and if these patients at the age of 55 were offered combined ARB plus SGLT2 inhibitor, we could offer at least 6 to 7 years additional life without ESRD, without transplant, without mortality. That is the difference that we can make, and it's a huge difference. People are elderly. If somebody at the age of 55 gets 8 to 9 years more without dialysis or without cardiovascular mortality, that's a huge difference that we can make. So obviously ARBs and SGLT2 inhibitors should be offered. Now it's almost a class 1 indication. That is what in this slide also I wanted to say. Role of nutrition in chronic kidney disease. I'll just take 2 more minutes. Nutrition becomes a very important thing for us nephrologists. The first thing that any patient does when they get a diagnosis of chronic kidney disease is they stop taking protein. That is the most difficult thing that we face because of malnutrition. So what we can, is there any data to support that? There is hardly any data. MDRD was the only largest randomized control trial. It did not show any benefit. In long term, beyond 6 years, it did show some difference. But in the short term, up to 6 years, they could not find any benefit with protein restriction. So the recommendation right now is 0.6 to 0.8 gram per kg body weight in patients who are metabolically stable or not malnourished. Okay. Okay. Your device ran into problem. I think time of me.
We can discuss in.
Okay.
Or you can have some concluding remarks.
So that is what we can do about it. That. तुम्हारा device बंद हो गया, time of me. So probably the time we have other sessions also. So what I would like to conclude with is. CKD is obviously a difficult thing to treat. It's a slow disease. So outcomes would not be apparent. Any interventions that we do, outcomes won't be apparent within within a short interval of 6 months, 1 year. It takes time. The whatever treatment that we offer, it takes time to manifest. What we can do in patients with ESRD, yes, I wanted to show the data of comparison between dialysis and transplant. We as a nephrologist are always asked about the outcomes of transplant in patients who reach ESRD. If we talk about survival of dialysis survival, the Western data says 9 to 10% mortality. So we are going to lose almost 50% of the patients by 5 to 6 years. If we talk about Indian patients, the mortality is close to 15 to 20%. Data is not there, that is what we see in practice. So by 3 years, we are going to lose half of our patients. If we compare that with transplant, if patient is suitable for transplant, the 5-year survival is more than 85%. So that is what we are going to offer, almost 60 to 70% more survival compared to dialysis. So any patient who is suitable for transplant has a donor available or a timely deceased donation available, then we must offer them transplant. So that is what I would like to conclude with. Timely diagnosis of chronic kidney disease, adequate management with good nutritional care, and good selection of patients and motivating them for either dialysis or transplant. That is what I would like to conclude. Thank you.
Excellent deliberation by Dr. Suraj Gupta. As you know, CKD is a disease multiplier. So for primary care physicians, I will like to add few more points here. In CKD management, one has to look into anemia part, control of hypertension, a good nutrition, control of infection, and the fifth and most important thing is you have to collectively see the general condition of the patient so that they can have an intervention during any emergencies. Like if any patient develops infection, he will develop acute on CKD, and if you don't interfere in the proper time, then you will find that he may develop acute on CKD, and with that delayed treatment, the patient may not have the baseline serum creatinine. So to intervene in the emergencies, you can have the management of the CKD patient properly so that they can achieve the baseline. That is very important. And with these words, I would like to have a comment from Dr. Anuj about diabetic CKD. You have some strategies to suggest to the audience for
Yes,
intervention in the progression of diabetic CKD.
So, as we see, the course of type 1 diabetes is quite different from type 2 diabetes mellitus in case of CKD. So, what is addition in type 2 diabetes mellitus? Lifestyle directly plays a role in genesis of complication. For example, insulin resistance and hyperinsulinemia, if you see organ after organ, they are the main factors in causation of disease. So in prevention of diabetic kidney disease, one of the main strategy we go for is weight loss. And second is not low protein diet, but low carbohydrate diet. Because low carbohydrate diet leads to decrease in insulin level, and that inhibits the main pathology that is caused by hyperinsulinemia, that is mesangial proliferation, as well as salt and water retention. So rather than focusing to protein, we should focus on carbohydrate.
Another important concept in dealing with the diabetes and CKD, we should not use the term diabetic nephropathy in most of our type 2 diabetes patients. We should not use diabetic kidney disease also, because except in young patient with a duration of diabetes of 10 or 15 years and having a histopathological evidence of diabetic nephropathy, in most of the elderly patient, these are the non-diabetic causes like the age-related glomerulosclerosis or some other loss either due to low birth weight. So other factors which causes the loss in the nephron number, they are operating. So we should not use the term diabetic nephropathy in most of the patient. We should not use the term diabetic kidney disease in most of the patient. Rather, for management of these patients, we should use the term CKD with diabetes, and we should focus on management of CKD in these patients.
I agree with Professor Om Kumar. In fact, the diabetic population, if they have a typical progression in the pathway of diabetic neuropathy, unless until proven by doing a biopsy, because these diabetic population may have an alternate pathway to develop chronic kidney disease and end-stage renal disease, and that is the reason these are the words to be used very carefully. Otherwise, yes, this is a very good question. The alternate pathway, the diabetic population who develop a CKD with an alternate pathway, and they are not biopsied, you will see two populations. The progression of the the progression of the CKD in the alternate pathway is slower than the diabetic pathway.
Another point is, if you are telling that it is diabetic nephropathy, then you will focus only on the glycemic control of that diabetes is causing all those problems. But if you are saying that it is CKD with diabetes, then you will focus on many other factors like hyperfiltration. You will target the upstream targets, hemodynamic factors, not only glycemic factors, hemodynamic factors, inflammatory factors, interstitial fibrosis factors. So that is how the concept differs in management of when you call it diabetic nephropathy or you call it CKD with diabetes.
And this alternate pathway has come, this concept of alternate pathway has come up for the last only 3-4 years. That is the thing we have to look into in future also. Dr. Abhishek, do you have any experience about this intervention in the progression of the CKD in ICU setup particularly?
Sir, good afternoon. Very nice presentation, Dr. Suraj sir. And you have very dynamic chairpersons, Dr. Om Kumar sir and Dr. Hemant sir, who have already discussed the topic. Yes, in critical care medicine, we do have patients who come, we come from the periphery, who have been, blindly been given for pedal edema. They have been put on diuretics, and they have come to us, with hyperkalemia, 6.4, 6.9 of potassium, and then we are at a dilemma when they have a good urine output. We have very few time to decide on whether people do not agree for dialysis. So that is the time when we have to tell them that only a urea creatinine is not a factor for going on to dialysis. There are many more factors, and to explain to them that about the edema which functions, which causes difficulty in day-to-day activities, the pulmonary edema, the resistant hyperkalemia, and that is where we face a problem in counseling them.
It is indeed difficult sometimes to counsel them. Patients are usually, as the data is there, in India almost more than 50% are diagnosed with CKD when they reach ESRD. So giving a diagnosis of ESRD to somebody who has just come and just got to know about it, and then telling them that you need dialysis and RRT, and then that too for lifelong, is indeed a very difficult thing and very challenging. But then, yes, one more thing that I would like to add is that, see, potassium, I would like to use that to talk about something else, is that in potassium is the hype that is created because of potassium. See, CKD5, CKD4 handle hyperkalemia very well. Unless and until their ECG changes or they are suffering with or they are having bradycardia, you don't actually need to worry. We can manage them medically. That is what we see in ACE inhibitor ARBs also. That there is a slight rise of potassium, that potassium goes to 5.7, 5.8, and in a knee-jerk reaction, anybody would stop ARBs or tell them that because of your potassium you can't take this drug. ARBs, ACE inhibitors, these are very important drugs for us. So before stopping these drugs or before telling them that okay, we don't take them, I think so. That is what we keep that in mind.
Just one short answer from
I
Dr.
think we are running
Divendu.
out of time. Other speakers.
When should we stop ACE and ARB to gain in terms of GFR, especially in elderly population?
When
If
should we
patient is
stop?
on ACE and ARB,
Yes, sir.
he is having advanced renal failure. Can we stop this ACE or ARB to gain in?
So, sir, if the ACE inhibitor or ARBs are increasing the creatinine level or further, or increasing the potassium level, then we can stop them. Yes.
So
otherwise, if it is not causing any adverse effect, then we can continue with them. Yes.
Sir, is there a cutoff, sir? Is there a cutoff in the creatinine value after which we should stop the ACE, ARB?
See, one thing I could not show that in the slide. That CJASN paper, what they tried to show was the number of years additional gained away protected from ESRD or cardiovascular event in a patient of CKD. In an elderly, the number of additional years would be less. So if somebody is above 75 or 80 or you are just putting them on ACE inhibitor or ARB because for kidney protection, that might be a little too much. So because we are not going to gain much because of that, and obviously risk of acute kidney injury and hyperkalemia and more in elderly compared to younger individuals. So that is what, and we talk about GFR, so there are easily available calculators on net, so we should use that.
With this, we close this session. Thank you very much, panelists. Thank you, Dr. Suraj.
Thank you.
Thank you, our chairpersons and speaker. As usual, our physicians had a lot of discussion. Now it's time for the surgeons who have been waiting eagerly for their talk. I would like to start the urology session, and I would like to invite our chairpersons first, Dr. Ranbir Prasad Singh, Senior Urologist, Patna, President of Urological Society of India, Bihar, and is also Organizing Chairman for USICON 2024. Dr. Vijay Kumar, Senior Urologist from Patna, ex-Head of Department and Professor IGIMS. Dr. Praveen Kumar Sinha, sir, Senior Urologist, Patna, ex-Assistant Professor IKDRC. And Dr. Amitabh Kumar Sinha, sir, Senior Urologist, Proprietor Sheela Urology from Patna. The talk is by Dr. Prabhat Ranjan on retrograde intrarenal surgery. I would request our chairperson to introduce our speaker. And we will take this, questions after the second talk of urology in the end.
सर बताइए सर यहाँ देखना है हाँ दे दिया हर सर को
Now we are having the urology session, and I present before you Dr. Prabhat Ranjan. He is consultant urology and kidney transplant surgeon at Jayaprabha Super Specialty Hospital. Did his MBBS from RMCH, Ranchi, and MS from Patna Medical College. He did DNB in urology from a very good urology center from Nadiad, one of the topmost urology center in India. He has been very instrumental in starting renal transplant program at Paras Hospital. He was a very good part of it, and also doing innovative things like RIRS, and has been an active participant in the transplant program at Paras. He specializes in endourology, laparoscopy, uro-oncology, andrology, pediatric urology, and he's planning for robotic surgery. Now, today he is going to talk about RIRS and its applications in urology. To Prabhat Ranjan.
Thank you, sir, for your kind introduction. Today I am going to present about RIRS. It's a very effective least invasive technique for management of renal stone diseases. Sir. So what are the treatment options available for renal stone diseases? We can go for ESWL, PCNL, or of course RIRS. So first coming to factors affecting treatment of renal calculi. These are stone factors, size of the stone, hardness of the stone, or its infective stone, or anatomic factors, whether stone in anatomically normal kidney, or if stone in ectopic kidney, malrotated kidney, or horseshoe kidney, and patient factors. If patient is having complex comorbid conditions, a patient is on bleeding diastasis. So these are the factors which affect the treatment of renal calculi. So coming to ESWL first. So ESWL has not stood the test of the time. It has got a high treatment rate and lower success rate observed in certain situations, like if it's impacted stone, or if it's a hard stone, or if there is distal obstruction, or a stone located in a dependent position, or if there is anatomical variations like ectopic kidney, horseshoe kidney, or stones that are difficult to localize with X-ray, like radiolucent stones. So coming to PCNL. We all know there is a risk of hemorrhage with PCNL. We are seeing patients with post-PCNL hemorrhage, and we have a cardiac and interventional radiologist team. They are managing post-PCNL hemorrhage with angioembolization. So longer stay with PCNL, at least 2 to 3 days, patient has to stay in the hospital, and of course positioning. We have to do PCNL in prone position, and patient with cardiac and respiratory issues, in that case again we cannot position the patient in prone. And if patient is on bleeding diastasis or antiplatelet, in that case again PCNL is challenging. So what observed, that less than perfect results are seen with ESWL when treating with urolithiasis, and there is risk of hemorrhagic complications with PCNL. So what procedure we choose? Procedure should be minimally invasive, there should be good stone clearance, and it should be cost effective. So what to do? We, the clinician, when treating the patients with urolithiasis, must ask, is the patient an appropriate candidate for shockwave lithotripsy or PCNL or other modality of treatment we can offer? Here RAS comes into the picture. RAS is retrograde intrarenal surgery, also known as flexible ureteroscopy. In this we enter through urethra into the kidney in any calyx, and there we do the job. So this is a representative case. This 49-year-old male having right upper ureteric calculus near Puget. ESWL was done. You can see in the middle picture that there was residual. For that RIS was done and a stone was cleared. So coming to the indications of RIRS. We can do RIRS in complex comorbid medical conditions, or patient who has failed or refused PCNL, and of course failed prior ESWL, failed medical therapy of radiolucent calculus. We can do RIRS in a solitary kidney, and when we want to do PCNL and RIRS simultaneously. Patient on bleeding diastasis, we can do RIRS, CKD with stone, patient on anticoagulant therapy, portal hypertension, morbidly obese patient in which positioning is again challenge, and severe kyphoscoliosis, again positioning is the concern. renal ectopia, urinary diversion, of course, diagnostic indications. So issues and challenges. Previously, it was thought that there is a steep learning curve for RIS, but now it's not so. We have to have a 3D picture of pelvic calyceal system, in which calyx stone is located, in which calyx we are going to enter. At the same time, we have to have orientation about flexible ureteroscope, how to handle it. And we have to train our brain and body to be standing in a standing position for a long time. And there is definitely initial cost investment and issues with the stone clearance. If we fragment the stone, it is difficult to pass. In that case, we do dormia for stone retrieval. Either we can go for dusting. And of course, scope durability. These scopes are vulnerable to damage, so we have to handle it with care. And sterilization, better to go with plasma sterilization. So in a small setup, it is difficult to have plasma sterilization. So in armamentarium, we have to have flexible ureteroscope, laser, and other accessories like XSC, dormia basket, ureteral dilators, wires, digestants, etc. So this is flexible ureteroscope. You can see the tip is bending almost 370 degree. These are laser machines, tabletop or with trolley. We have 100-watt luminous laser. These are dormia baskets for stone retrieval or manipulating a stone from one calyx to other calyx. So coming to initial cost investment. Flexible ureteroscope are available in the market either fiber optic or digital. Fiber optic, Storz, Olympus, Wolf, and digital. We have FlexXC digital variant from Karl Storz. Newer disposable scopes are also available from Biorad and UMD. So initial cost investment in reusable flexible scopes are 5 to 6 lakhs. So we have to have a laser also. So in this again around 20 to 30 lakhs investment is there. So advantage of laser. So it evaporates or makes very small tiny fragments so that it will comes out with irrigation. Can fragment any hardest stone. There is no or minimal retropulsion and zone of thermal injury is very less. That is around 0.5 mm. So I am showing one representative video. Oh. Huh. आस्तोष कहाँ है? आस्तोष, अरे आस्तोष, इसको बढ़ाएं कैसे? नहीं इसको बढ़ाएंगे, ऑडियो नहीं बढ़ाएंगे कैसे इसको? कहीं तो है नहीं, आइकॉन नहीं है। हाँ? तो बढ़ेगा तो बड़ा नहीं, तो बहुत बड़ा है। हाँ तो कोई बात नहीं, वो नीचे हमने दी वो स्लाइड से हटाएंगे तो। So we have entered into the kidney. You can see the stone. It's a very clear view. नहीं बढ़ेगा, बढ़ाना है। बोले ना प्रॉब्लम होगा, हम जानते थे बढ़ेगा नहीं। स्पीकर से क्या होगा? बढ़ाना है वीडियो। वैसे देखिए रहेगा। थोड़ा देर चलने तो फिर बंद कर देंगे। हाँ ठीक है। Actually, it's a 4-5 minutes video. I will cut it short. I have no control over this actually. There is no control here. So we can see a laser fiber is just touching the stone. Now we will start fragmenting the stone. There is a stone fragmentation. We are fragmenting the stone and making stone into very small pieces. So, take-home message is in properly selected cases, RIRS is increasingly being used with good results. Few lower calcial stones and large stones more than 2 centimeters are still challenging for RIRS. Thank you.
Thank you, Prabhat, and good evening, everyone. Thanks, Medanta and Prabhat. So I think we can start another topic, and then we'll just take the question in.
Yes, sir. Due to paucity of time, we'll do that.
Paucity of time, I
and
think.
it is a urology topic only. It's a guest lecture from Dr. Prasun Ghosh, who is Senior Director, Urology, Robotics and Renal Transplant from Medanta, Gurgaon.
Dr. Prasun Ghosh, please.
So he'll be talking on robotic renal transplantation, conquering new frontiers.
Okay.
And I also like to invite Dr. Pankaj Hans to please come and join us as a panelist. He's Senior Nephrologist, Assistant Professor PMCH and Reuben Hospital.
I think it will be better, Pankaj, to introduce Dr. Prasun Ghosh.
Good evening, everyone. Actually, I am the only odd man out in this session, the only nephrologist in this session of urology. Dr. Prasun Ghosh, actually, he holds a very special interest in the field of renal transplantation. Apart from his vast experience in minimally invasive and robotic urology surgery, he has pioneered the first robotic renal transplant recipient surgery in this part of the world. He trained at the Roswell Park Cancer Institute, New York, for his robotic training and has worked with some of the renowned robotic surgeons since 2006. Dr. Ghosh also specializes in robotics and minimally invasive technique of challenging urologic cancer and non-cancerous surgeries. Apart from setting up dedicated kidney transplant programs in 3 private hospitals, he has also pioneered the initiation of robotic surgery in these hospitals and has been actively involved in shaping the current renal transplant and robotic renal transplant program at Medanta. He has also the vast experience of working in the world's leading hospitals such as Indraprastha Apollo Hospital, Fortis Hospital, Delhi, and Ravindranath Tagore Hospital College in Udaipur. Dr. Prasun Ghosh, please.
Thank you very much for the kind introduction. I'll try to make this as short as possible, as quick as possible, and as interesting as possible. So, I'll be talking about a very offbeat topic. We all know about renal transplant, and our nephrology colleagues have very well elaborated on the fact that CKD is a problem, ESRD is a bigger problem, and renal transplant accessible to few is the biggest challenge to it, although it is the best form of treatment of ESRD. I bring greetings from Medanta, the Medicity, the Kidney and the Urology Institute, Gurugram. So, if I look at the transplant program and the journey that we had begun in 2009, so we are a fairly active transplant centers and on the average do about 250 to 300 transplants a year, which includes the routine transplant, ABO incompatible, HLA mismatch, second, third, fourth transplants, pediatric transplants, complex transplants requiring reconstruction of bladder from the bowel segments, swaps, salvage procedures of renal transplant like graft ureteric strictures, malignancies, reimplants, etc. and of course, the high-risk transplants. So, if I just kind of summarize our journey, to date, till February, we have done about 2,658 transplants. Multiply it by 2, you are close to 5,000 patients, because that also involves a donor, of which our cadaver program is not very active, I'll be very honest with you. So till now we have done about 19 or 20, we did one a few days back. Initially we started doing the donor also with the robot, but we found it was a fruitless job. It could be done better with laparoscopic surgery. Of the recipients, about 2,658, about 2,400 we have done open, and our tally stands for the robotic transplant 250 plus presently. The spread of our work is well elaborated here, and the interesting part is that we didn't stop even in COVID, except for the first few months where we were recalibrating our approach towards transplant. Should we do it? Should we not do it? What are the precautions that we need to take? So on and so forth. And we still managed close to about 250, 300 transplants in these 2 years. Now, transplant was always challenging and as a surgical exercise. So this has been done as an open approach starting 1950s. Most of the surgeons would do it in an open way, and it was standardized till about, and trust me, fantastic advancements were made in the field of immunology and the medical part of renal transplant. But nobody focused on the surgical aspect of it. We all know the minimal advantages, the advantages of minimal invasive surgery, and they are well established. Somewhere in the late 90s, laparoscopic donor nephrectomy came into effect, which were resisted by few, accepted by even fewer, and finally by the beginning of this millennium, laparoscopic donor nephrectomy started catching the interest of urology surgeons and transplant surgeons worldwide. By now, it is established procedure and is being offered as a standard of care everywhere. But minimally invasive surgery, trust me, is technically challenging, especially in the transplant scenario of the recipient, where you have to do vascular anastomosis, which are more difficult to perform with, by virtue of use of long instruments which amplify the surgeon's tremor, absolutely poor ergonomics, and the inability to achieve a cold ischemia while you are doing that vascular anastomosis, because it has a direct effect on the graft outcome. So this was a thought process that we started to build on. And then at the side by side, we reasoned that if healthy donors and other people obtain a benefit from the minimally invasive surgery, why can't we translate these benefits into the relatively sick, cachectic, immunocompromised recipients? They would benefit out of this procedure the most. We are all aware that complications arising out of surgery not only affect the short-term patient's convalescence, but also compromise long-term graft outcomes. So, if you put the two together, the transplant recipients may actually gain substantially from a minimally invasive procedure on them. So we started raking up the literature, and we found out that surgeons from our country, they have done a fantastic job, especially Dr. Modi from IKDRC, regarding laparoscopic recipient surgeries. So he started publishing in 2009, 2010. Then this obviously shifted on to better version of laparoscopy, which is the robotics. This paper, the one you see on your right hand side of the screen, is coming from Oberholzer in Chicago. He offered a robotic platform to it. I will explain that part in a bit of time. So somewhere around 100 cases, when Dr. Modi was at it, we had a personal chat with him. These were all extremely technically challenging. Now you have to be actually blessed with an exceptional laparoscopic skill set to translate into good outcomes. But the magic was when you use this at a robotic platform, you are actually able to counteract these very challenges and translate to safer outcomes. So for people, most of us are familiar with the robot, so let me explain a bit of it. So here is a surgical robot, it's the central column. You see 1, 2, 3, 4 numbered arms over there. These are actually the arms which hold the instrument. The central black panel on the arm is the camera holder. On the right hand side of your screen is the surgical console. And I could not take the vision card properly, but there is a TV unit attached to it as well. Now people who are interested in video games, especially children who will grow up to become good robotic surgeons, This is the surgical controls and actually looks like the cockpit of an aircraft. The two holes that you see there is actually your eye placement units where you just put your head inside. And if you close up on that, you have finger controls right at the base where there's a white marker right in the middle. You have finger controls beyond that. You have switches to switch it on, switch it off. You have ergonomic controls on your left hand side of the screen. If I go one step further, it's like driving a car. You have a clutch which is marked with an S, which switches between arms during surgeries. You have a camera console which can magnify, go in, go out, turn left, turn right, clockwise, anti-clockwise. You name it and it does it. The two blue pedals that you see are for coagulation purposes for monopolar and bipolar cauteries. Now the advantages of a robotic system is the surgeon is completely dissociated from the operative field. You can have a single console setup where the main surgeon operates the entire case, or you can have a dual console used for teaching purposes and translate the skill set to the coming generations and your residents and fellows. I'll play a short video here just to make you understand how a robotic surgery looks like. Can we have the audio, please? IT. Can we have the audio? So you can see my surgical assistants are absolutely sitting comfortably on a chair. You have the video controls over there. You can see the procedure going inside. What you are seeing in 2D and what the surgeon is seeing inside is in 3D. So it is actually you are sitting inside the patient's abdomen and doing the surgery. It is a very comfortable situation. Trust me. So whenever you are developing a new procedure, what is the challenge that you would go to, that you will accept? What are the guidelines? There is no precedence to it. How will you formulate something which is absolutely new on the surgical front? Now, precisely aimed at this, we designed our study as per guidelines from the Ideal Collaboration, which came to be known as Ideal Guidelines. It's an acronym which stands for about the idea, the development, the exploration, the assessment, and long-term study. Now, if you look at the literature, multiple RCTs, or majorly 50% of the RCTs in medical literature comes out of medical care. Surgical RCTs don't exist much. So in 2007 at Oxford, a group of surgeons, methodologists, statisticians, they all got together to find a way out of how to standardize the surgical procedure. And this was known as the Balliol conferences. They had about 6 or 7 of them. And then finally they decided to come back and summarize it into what we call now as the Ideal Guidelines. So it kind of is a situation where you have the first in human to a long-term follow-up. It follows each and every step, documents everything, analyzes every step. And this was adopted by many teams to develop procedures like of surgical, to validate new surgical techniques, especially like robotic esophagectomy, HIFU, for uterine fibroids, etc. So as you progress along the track of surgical expertise, you go through these various phases. I think I've already explained this, where the initial report comes in, so that would be the phase 1. That's your idea that you are tinkering with. You will be the only surgeon who is doing it. You would be explaining more on the focusing more on the description of the procedure and how to do it safely. Phase 2 would kind of go ahead into other people kind of tinkering with the idea, modification of the technique. You may have a small experience from a particular center which focuses on technical details and the feasibility of it. Phase 2B is a bit more higher, more people are now doing it, replication by others, and the focus, instead being on the technique, it's on adverse events and other things. The learning curve at this point becomes important. As you move on to phase 3, now this procedure is slowly gaining wide acceptance. And it could it be considered as a possible replacement of the current treatment? And also, it obviously brings in the question of comparison between the existing method and the one that you are designing. And then obviously we all know we have to look at the long-term outcomes. So how do we go about it? So somewhere in 2011, in collaboration with Vaticute Institute of Technology in Detroit, we did a cadaver trial. There was this cadaver we had. We kind of removed the kidney robotically from the same patient and implanted it into the right iliac fossa using the robotic technique and the one that we had designed. So we standardized a few things, how to position the patient, how to dock the robot, where to place the ports, choice of instruments, sutures, so on and so forth. Going a step further, after we did the anastomosis and everything, we had documented everything in details, including console time, OR time, everything. We kind of cut through the anastomosis to test the strength and integrity of it, because especially with minimally invasive surgery, you do not have immediate access to a complication as in open surgery. You have to open up the cavity to reach there actually. So we had documented almost everything, OR time, console time, ischemia time, so on and so forth. Our trial began in 2013, 7 patients for the phase 1, 25 patients for the phase 2. We started timeline management for phase 1 and 2A, where the technical modifications, whatever we did, were documented on a timeline as per the case numbers. What modifications did we make? The first publication came out in 2013-14, and this was a pilot trial of comparing 79 patients versus robotic patients to 350 patients, and I will not go into the details of it, but by virtue of it, we were able to kind of formulate a procedure of how to do it. We could offer it as a safe, feasible alternative to the open transplant. So not only did the procedure gain acceptance in India, in IKDRC, Ahmedabad, Nadia, Kochi, Bangalore, the big transplant centers who had a robot in place accepted this program. But we also went out and taught the entire world of how to do it safely. Spain, Turkey, the list is endless. It is endless. So we still have fellows and researchers coming in from other places at our institute to learn this program. Now with this background, I would like you to introduce what we introduced to the world in 2012, the robotic kidney transplant. Gentlemen, here it goes.
In this video, we describe our novel technique of robotic kidney transplantation with regional hypothermia. With the patient in supine position, a 4 to 5 centimeter periumbilical incision is made and extended down to the fascia. After the peritoneum is opened, the gel point access port is placed through the incision. Then, a gel seal cap prepared previously with a 12 mm camera port and a 10 mm assistant port is fastened onto the gel point access port. Pneumoperitoneum is established and the patient is moved to a 15 to 20 degrees Trendelenburg position. The post placement is similar to a typical robotic radical prostatectomy port placement, with the fourth arm on the patient's left side. The surgery starts with the identification of the external iliac vessels, which are then carefully skeletonized, exposing the external iliac artery first, followed by the external iliac vein. Small branches and the lymphatics are controlled. The peritoneum distal to the cecum is divided transversely, and the proximal and distal flaps are raised. These flaps will be used later for retroperitoneal fixation of the graft after the vascular anastomoses have been done. The bladder is then taken down and the extraperitoneal space is developed. The bladder is then distented with saline through the urethral catheter for creation of a 1.5 to 2 centimeter orifice for a subsequent ureteroneocystostomy. After harvesting the graft kidney laparoscopically, it is defatted on the table. Simultaneously, modified 2V syringes are prepared with ice slush for rapid delivery of the ice slush to the pelvic cavity. Then the graft kidney is wrapped in a gauze jacket with the ice slush. An opening is fashioned to allow access to the hilar structures. The jacket serves a dual purpose of maintaining ice slush around the graft as well as allowing atraumatic handling. The robotic camera arm is then de-docked and the gel scal cap is removed, which allow for easy and resistance-free introduction of the graft kidney into the pelvic cavity. After stabilizing the graft kidney with or without the assistance of the fourth robotic arm, the external iliac vein is clamped using robotic bulldog clamps. A venotomy is made using cold monopolar scissors. The graft renal vein is then anastomosed in a end-to-side continuous fashion to the external iliac vein using a Grotex CV6 suture beginning with the posterior wall. This PTFE non-absorbable monofilament suture slides through the tissues easily and is strong enough for use with robotic instruments. The anastomosis is flushed with heparinized saline and is then completed. The graft renal vein is then occluded using a bulldog clamp. Both proximal and distal clamps are then removed from the external iliac vein. Next, in a similar fashion, the external iliac artery is clamped. For arteriotomy, first a small incision is made in the arterial wall using either the monopolar scissors or the robotic scalpel. With the help of a 3.6 mm aortic punch introduced through the gel point, a circular arteriotomy is made. The renal artery is anastomosed in an end-to-side continuous fashion to the external iliac artery. Black diamond forceps in the non-dominant hand helps in atraumatic handling of vascular tissue and is useful to spread the vascular margin for precise needle placement. The anastomosis is flushed and the integrity of the anastomosis is checked. The graft renal artery is temporarily occluded and the clamps are taken off the external iliac artery. The vessels are then unclamped, the gauze jacket is carefully cut off and removed. The graft kidney is visually inspected for color, turgor and on table diuresis. The graft kidney is retroperitonealized using the flaps prepared previously. Also, the pneumoperitoneum is dropped to 8 mm of mercury. After this, an IV bolus of 100 mg of furosemide is given. After fixation of the graft, its color and turgor is reassessed and the vascular anastomoses are inspected. We then proceed with ureteroneocystostomy utilizing the modified Lish-Greger technique. The ureter is spatulated and is anastomosed with the opening in bladder mucosa in a continuous fashion using 4-0 PDS or Vicryl suture. A double J stent is placed after completion of the posterior layer and ureterovesicostomy is completed. The detrusor layer is closed in a continuous fashion using a barbed suture such as a V-lock 3-0. The abdomen is closed in conventional manner after placing. At finish, an on-table Doppler is performed to check the graft perfusion before shifting the patient to transplant recovery.
Thank you for this video. I hope you enjoyed it, and what I was trying to explain here, you would have noticed the dexterity of the movement of the robotic arm. Unlike laparoscopy where the fulcrum is at the point of entry, the robotic instruments moves like an endorist. Whatever I am doing on that console, robotic console, my instruments are replicating the exact movement without tremors, without shake, and it scales the movement down to any level you want to. The advantage is being I am seeing it in 3D and it is a rock steady camera. It does not move. So I will run quickly through the results that we got, the main important parts. The blood loss dramatically decreased. The incision went smaller. The pain score was significantly lower in the robotic group to the tune of 2 paracetamol tablets for the entire transplant stay. For the, for the functional outcomes, as we progressed down the line, we started doing more complex cases, preemptive transplants, multiple vessels. Our total operative time increased marginally because of the complexity of the case, but the anastomosis time and the ischemia times remained the same as compared to the open group. So I'll just quickly go through it. The important functional outcome that about at discharge, the biggest disadvantages to the laparoscopic laparoscopic procedure was at the time of discharge, the discharge creatinine was higher. And for the robotic that Oberholzer proposed, he did not institute intracorporeal hypothermia. Now you are on a learning curve. The kidney needs to be cooled down for a certain limit before you can actually deliver anastomosis or shorter anastomosis time. So with this you can see for the robotic transplant at discharge it was about 1.2, almost comparable. And till about 4 years of follow-up we have almost comparable outcomes to the open group. Interestingly, the complications, the medical and the surgical that you were talking about, there was no change in the medical complication that would have occurred. Urinary tract infections, graft dialysis, rejection, so on and so forth. But there was an absolutely significant drop in the surgical complications arising out of kidney transplant. So, in terms of the Clave and Dindo classification for surgical complication grading, we saw maximally grade 1 and grade 2. And essentially they were obviously as expected lower in the robotic group. We published our data extensively, more than 15 publications in peer-reviewed journals. We have about 4 chapters in books. We have a section in Campbell's Urology, which is the Bible of urology across the world. And we also have a chapter in Smith's textbook of urology. Our last publication came out 2020 during COVID period. We did not have enough people to manage the data, which was a propensity matched trial between multiple vessels for the robotic kidney transplant. So what are we doing right now? Right now we are in a randomized controlled trial phase 3, which is the kind of benchmark for any surgical procedure. So we have already finished the prospective randomized trial, and the primary objectives, secondary objectives are well defined. Data is being analyzed, and we are on the verge of a publication coming out soon. And before I end this talk, I must acknowledge the entire Medanta Medicity, doctors, nurses, paramedics, ethics committee, and everyone, urology team, nephrology, anesthesia, blood bank, and everyone. I will leave you with a few images to consider, where we did a robotic transplant in patients, and this guy actually came back to us to ask for a certificate because his office would not believe he's had a transplant. So we had to issue him one. So there were no wound infections, no lymphocytes, etc. noted. Excellent cosmesis, minimal pain score, early return to work. So these are a few things I would like to share with you for the August gathering. I end my talk here and I'm open to any questions.
Thank you, Prashant.
Thank you very much.
Please have a seat. If you question there. So I must thank the Medanta and the organizers for organizing this wonderful show. All the qualified doctors from all over the state and outside the state were called, and we had a discussion. First we will go to Prabhat. What he has said, that is very nice, both one robotic and one minimally invasive surgery. But everyone must have seen needs expertise, and every operation has its own yes and no. So open surgery is obsolete right now. The PCNL, the RIRS, the other ESWL, everyone has its own say. You need expertise, you need training and the equipments. And a Staghorn calculus by RIRS will take hours together. But in a difficult situation of calyceal stone, it is excellent. Minimal complications and all. So we have one person doing only PCNL in India. Another is only doing RIRS in this country. Someone is doing only ESWL, which has miserably failed in practice. So these are the things we have to choose the case. You have to weigh yourself and your equipments and the setup. So now I go for the anything you want to.
One thing I would like to ask, especially Prabhat, with modern investigative techniques, you must be getting good number of asymptomatic subcentric calyceal stones.
Sure.
The patient is not having for ultrasound or imaging done for anything else, and you find we frequently get good number of cases. Usually we keep it for follow-up, just surveillance, and avoid surgery for various multiple. How do you find RIRS safe for these asymptomatic calyceal stones?
If a stone size is say 7-8 mm, so it's very difficult to get out itself. In some cases it may come out, but at the same time, if it's not symptomatic, then I counsel the patient that you can choose for RIRS. We can make you stone free, but you can at the same time we can keep you observing whether stone size is increasing or not. So both options we discuss the patient.
A common scenario that we get in the society is that a person has got for his naval merchant services. He is having a 3-4 mm stone as he has been rejected for going on the ship. Whenever you ask for one ultrasound, they say that there is a 3 mm stone, other place they say it's nothing. Then they want a certificate. Whether you should proceed with the procedure and then declare that he is stoneless at present and now he can go to the services, or what to do in that case. This is a very important situation. And the second question, what is the minimum age for which you have done RIRS and you recommend that RIRS can be done with that age? It definitely depends upon your armamentarium.
So coming to first question, if a stone size is 3-4 mm and his patient is has to go for merchant navy job, in that case we can offer him, we can make him stone free, because we have to save his job actually. So that's not clear indication for doing RIRS, but for his job sake, we can go for that.
As a matter of discussion, Dr. Vijay, you have been professor and HOD at IGMS. Can you offer a certificate that the patient is having asymptomatic and that you can ask the radiology department to render him without a stone?
I have encountered such situations, especially when people, young boys selected for going to army and they are refused their job on petty grounds of having a varicocele or some hydrocele. Stone, we can't give a certificate that there is no stone unless we get a NCCT done. Then only we can say. But I have seen, I have given certificates for trivial, just flimsy ground hydrocele and another thing. I have written, got an ultrasound done and given him a certificate that this is not of surgical significance.
Yes. Dr. Prabhat, it's no harm in taking out 3 or 4 mm stone for somebody's sake, job sake. But what about the Randall's plaque? They are also picked up in CT scan and they will say it's a 3-4 mm. Are you planning to lace those plaques?
No.
Then you can't leave that, because on CT they have been picked as 3 mm stone and patient cannot join.
At that time I will make him stone free. He will get his job. Again, Randall's plaque again may develop into stone. But all Randall's plaque I can't handle. I should not handle.
For a person who is in a job of serious in nature, surgeon, aeroplane pilot, navy, or engineers going inside the navy, ship. So all these persons must be made stone free before they go to the ship. Otherwise, it is your choice and the patient's choice that you can come and regular treatment. But for those who are in the emergency job and they can't get the treatment in that situation, he has to make a stone free. That should be the principle of all doctors.
Other option with the patient to change the job.
And about the procedure, Dr. Mahat, do you always take consent for 2-stage procedure?
The
for RIRS?
Organizers are pressing for short of time. So you can please complete it.
Usually I do primary RIRS. Usually 90% cases of mine is primary. But if ureter is non-dilatable, that in that case we have to stage the procedure. So beforehand we have to counsel the patient that we may put a stent and call after say 2 weeks, then ureter will get passively dilated, then we will go for.
Do you go ahead with RIRS without excess sheath?
Yes, sometimes.
Yeah, Dr. Prasoon, excellent talk. Just one question from you, that many patients go to Delhi and they get robotic kidney transplantation done. After coming back from there, after suppose 6 to 9 months, they develop rejection. So we are facing lots of difficulty in doing kidney biopsy upon these patients because the organ is intraperitoneal. So any simplified version of biopsy that you will suggest for such patients?
So excellent question. The biggest disadvantage to the robotic, or the biggest speed breaker that was put up in a world forum, was inability to biopsy. When Oberholzer published his paper, his nephrology colleagues, they had to biopsy 6 patients of those 47 group. For them, they had to do open biopsies in 3. They had to open the guy up, which was not acceptable. So if you would follow the timeline that I showed, we picked up all the important contrasting points. Whatever was the controversy, we could not biopsy, where to put the robot, everything. So if you would have noticed the video, after the transplant is done, the kidney is put back into the left iliac fossa and a fold of peritoneum is drawn over it to fix it completely to the anterior abdominal wall. So if it is fixed there, it is just, your biopsy gun is just a skin deep, that's it. So the fixation is very important. So that's why you create the bed in a way where you have the flaps to fix the kidney after you have implanted.
One patient who was himself a doctor from Gaya, he underwent this surgery at Max Hospital, Saket. And we didn't biopsy because the surgeon who operated, he asked me to send the patient for laparoscopic kidney biopsy upon that patient actually.
Yeah, so these are genuine problems we have to encounter, and we have to preempt these problems and act beforehand. We have to fix it nicely to the lateral abdominal wall, so that it's just skin deep.
Prasoon, just
Sir.
I was engaged in this transplant business in 88 to 91
Sir.
at CMC Vellore, and that was a center which was doing the regular transplant 3 in a week. The catastrophe any time you have faced in the life of this transplant during the surgery, which you never expected.
Are you talking about the robotic transplant?
I am first talking laparoscopic.
We have never done a laparoscopic transplant.
Okay. So in any catastrophe in the robotic transplant during the procedure, either donor or the recipient?
No, donor surgery is never a challenge to us because we are protocolized to the last extent of till the extraction. In terms, when we were developing the robotic program, we had factorized all these things. Now, I could not spend much time on that consort diagram of the patients, but we had been very selective with our recipients. Active atherosclerosis, vascular leaks, difficult cardiac functions, very low ejection fraction, some ocular changes, these were all simply rejected because that was the initiation of our program. So in terms of catastrophe, if you ask me, for the first 7 patients, I had to re-explore one of them because he had atherosclerosis, which we could not anticipate, and he was leaking from the anastomotic site. So it was in a matter of 45 minutes that we went in, and the second approach usually is the standard Gibson's or the right iliac fossa incision where you open him up and fix it up. But the vessels were pretty atherosclerotic, and that was the issue. The needle cannot go through a calcified plaque. So the sutures were a bit loose. That's about it.
No, what is happening that open surgery is obsolete now. So you have to call some open surgeon who can open the thing and do the job.
I would disagree on that, sir. I would completely disagree on that. Open surgery is the backbone to the minimally invasive.
Yes.
You cannot be a good minimally invasive surgeon if you are not fluent with your open surgery. So if you look at what we did,
that's the message we wanted to
to everyone. You have to be really fluent with your open surgery.
Still, and any time you will need it.
So we had a huge robotic experience as well as open transplant surgery experience. The challenge and the trick was to fuse them together. So we replicated all the steps of open surgery in the on the robotic platform. And it stands to date pretty strong.
Sorry, I couldn't take question from the audience. They are praising that every time.
Sir, can we take during the tea session, sir? Actually, we are 1 hour late.
Thank you so much.
Thank you, sir.
Thank you so much.
Thank you.
So, please remain here for the felicitation ceremony. Dr. Prabhat sir, please felicitate our guest speaker from Medanta, Gurgaon, Dr. Prasoon.
हाँ बस निकलना है क्या आपको? पालिका का बोर्ड कल शाम में नहीं आया सर, कल शाम में नहीं आया। ऐसा है सर,
कल शाम पे मैंने आज देखा।
हम लड़का लोग को बोले थे कि दिखला के।
डॉक्टर रणबीर प्रसाद सिंह, प्रोफेसर प्लीज।
के बाद सो जाता हूँ, आया जब मैं सो गया।
हमको रवि कहते हैं अपने अपनी पालिका को जरूर है।
डॉक्टर विजय कुमार सर। डॉक्टर प्रवीण कुमार सिन्हा सर। डॉक्टर अमिताभ कुमार सिन्हा सर। डॉक्टर पंकज हंस सर। I would request Dr. Ranbir sir to please felicitate Dr. Prabhat sir.
Thank you.
Thank you, sir. I'd request our chairpersons from the former session, nephrology session, to come on the dais for felicitation. Dr. Om Kumar sir, Dr. Hemant Kumar sir, Dr. Devendu Bhushan sir, Dr. Kumar Anuj, Dr. Abhishek Chaudhary. Please join us on the dais. I'd request Dr. Suraj to please felicitate the chairpersons.
निकलिए सर अभी सुनो ना सर निकलिए सर का मोमेंट लैपटॉप
I would request Dr. Om Kumar sir to felicitate Dr. Suraj sir.
Dr. Sanjay Dr. Sanjay.
आपके साथ एक डॉक्टर आलोक और बैठा है
Thank you, chairpersons and speaker. It was a rather stimulating session. Now we are running late on time, so we'll start quickly with our next session on gastrosciences. I'll request our chairperson to come on stage, Dr. K.N. Sinha sir, Senior Laparoscopic and General Surgeon, Head of Surgical Division, Reuben Hospital. Dr. Vijay Mittal sir, Senior Laparoscopic and General Surgeon, Head of Surgery, Big Apollo Hospital. And I'll request Dr. Next session chairpersons also to join us on this stage, Dr. Ramesh Kumar sir and Dr. Utpal Anand sir, Head of GI Surgery, AIIMS Patna. The first talk will be by Dr. Sanjay Kumar, Director, Gastrosurgery, Jayaprabha Medanta Hospital. He'll be talking us on management of bile duct stones in the era of laparoscopic surgery. We'll take the questions after the session.
Request you to keep with the time, please. Huh? We are running late, so it will be 9 o'clock then. So please. So request all of you to adhere with the time. Thank you.
I'll call one chairperson more. Dr. Alok is a professor at Narayana Medical College. Dr. Alok.
Hello, good afternoon.
Rather good evening. I have a pleasant work to introduce Dr. Sanjay Kumar. I was trying to cut the chase and go to the topic, but I suppose there are few people who doesn't know him. Dr. Sanjay Kumar is Director GI Surgery, GI Oncology and Bariatric Surgery in Jayaprabha Medanta Super Specialty Hospital, Patna. He completed his MBBS from NMCH, Patna, and MS from PMCH, Patna. Dr. Kumar pursued his higher surgical training in UK and advanced laparoscopic surgery from which was hospital? Newell Hospital, Dundee. He was has over 25 years experience and holds expertise in gastrointestinal surgery, therapeutic endoscopy, colorectal surgery, hernia surgery, and hepatobiliary surgery. He has performed over 25,000 gastrointestinal surgeries using laparoscopic and open technique and maximum number of bile duct surgeries in the state. Dr. Sanjay Kumar also pioneered laparoscopic diaphragmatic hernia repair in Bihar. Okay, but on a personal note, I would say that I have a privilege of working with Dr. Kumar for over 20 years. And as far as the topic of his lecture today is concerned, approach to stone in CBD, I think there cannot be any better person than him, because as far as I know, there are very few surgeons who can deal with CBD stone by all the three modalities, like open surgery, laparoscopic surgery, or endoscopic surgery. So let us hear what he has to say, and then we will discuss about it.
Thank you, Chairman, sir. The distinguished guests in our audience and dear friends. Prior to the advent of endoscopy and laparoscopy, there was only one way of dealing with bile duct stones, and that was by open surgery. But in 1974, the ERCP became introduced into clinical practice, and following that, things developed, and open CBD exploration nearly went out of common usage. It was done very infrequently at good centers. First, it was the fiber optic endoscopy, and later on, over 15 to 20 years, the video endoscope was developed. With that, the skills of the endoscopist also developed, and good imaging led to better results. Also, during this period, the imaging modalities improved, whereby more CBD stones could be diagnosed. So after transabdominal ultrasound came CT and MRCP, and finally endoscopic ultrasound. In 1990, laparoscopic cholecystectomy got established, and over the next 10 years, nearly all of the GI surgical procedures were started to be done laparoscopically, and most of them were did laparoscopically, and so was CBD exploration. During this time, the instrumentation, imaging, and the equipment also improved, and that led to the introduction of CBD exploration as well. So why do we worry about CBD stones? Of all the laparoscopic cholecystectomy or cholecystectomies we undertake, about 8 to 12% of them may harbor CBD stones, and this increases with age, so much so that over 80 years of age, nearly 25 to 30% of the patients may have CBD stones, and about 10% of them may be asymptomatic. So how do we suspect CBD stones? We do it by the clinical features, by a history, clinical features, abnormal biochemical test, and by imaging modalities. The imaging modalities available to us, the first is this transabdominal ultrasound, which is most commonly used. It is accurate in about 80 to 85% of the cases, other can be missed. MRCP gives us about 95% reliability. CT per se is not used to diagnose CBD stones as much as it is to rule out some coexisting pathology, and sometimes for doing a surgery we need some more information on the gallbladder, which we can do it in doubtful cases. Endoscopic ultrasound is very good in picking up small stones and giving more information about CBD. It is relatively scarce to find. It is operator dependent. The other two modalities, intraoperative cholangiogram and laparoscopic ultrasound, are done during the surgery and can be done. So this is an example. This is a ERCP being done, and a small stone is retrieved. Now this was missed both on the MRCP examination done and a diagnostic ERCP done, but it is picked up well on the endoscopic ultrasound, and this has been removed. So this gives us an idea how endoscopic ultrasound is so useful in very small stones. So the present management strategy of CVD stones involves either an endoscopic clearance of the bile duct followed by laparoscopic removal of gallbladder, or a surgical exploration and clearance of CVD, which can be done either laparoscopically or by the open method. ERCP and stone extraction followed by lap cholecystectomy is the standard of care, but now with improved surgical expertise in laparoscopic procedure, many surgeons are now offering lap CVD as a single stage treatment to the patient. So the options, So the options before us are either preoperative ERCP, which is the most common method of dealing with them. It can be done intraoperative ERCP, but there are some logistic problem with having the endoscopic equipment in the theater suite and also the endoscopist to do it. Postoperative ERCP sometimes has to be done, but sometimes it is limited by previous gastric surgery or large duodenal diverticulum, which may prevent doing it. Both the European Society and American counterpart have done clinical trials, and they found that lap CVD exploration is equally good in successful clearance of the stones, and it results in a shorter hospital stay and probably reduced costs. Open cholecystectomy and CVD exploration still is done when the other methods fail. This is an interesting Cochrane systematic review that came in 2006. It consists of meta-analysis of 13 RCTs. And this came out with certain interesting observations. In open surgery, had a superior stone clearance rate. Both ERCP and lap CVD have similar outcomes with regards to morbidity and mortality as well. Intraoperative ERCP has less morbidity. But in real life, both lap CVD exploration and ERCP were rarely practiced. So how do I deal with bile duct stones? I try to give my patients a single day solution to this problem. I have access to this ERCP scope and the choledocoscope and laparoscopic equipment for doing CVD explorations since 2008. I have been doing this since 2008, and I first offer them a ERCP in cases which have a bile duct stone size, bile duct stone size of less than 15 millimeter, which are simple to do, and the CVD size is less than 1 centimeter. So I start with doing a ERCP. Usually it is straightforward in 80% of the cases. It is done in 15, 20 minutes, 25 minutes. And if the abdominal distension is not much, I straight away go and do a laparoscopic cholecystectomy. However, if the ERCP sometimes is difficult to clear the stones and takes a longer time, and I have to do balloon dilatation, then I would worry for postoperative pancreatitis. Then I wait for a couple of days, and once the patient settles down, then I do a laparoscopic cholecystectomy. If the CVD size is more than 1 centimeter and the stones are large in size, like 2 centimeter stones, I straight away go and offer them a lap CVD exploration. And I reserve open cholecystectomy if during my initial ERCP, if it fails completely and the patient is already under general anesthetic, I try to clear it by doing open cholecystectomy and CVD exploration. Lap CVD exploration is done in one of two ways. They are not equivalent. They have different indications. It can be done through the transcystic route and rather transductal. In transcystic, you need a smaller stones, fewer in number. These are the stone sizes I do by ERCP. Transductal needs the duct size of more than 1 centimeter. Transcystic is done through the cystic duct. 200 ml of saline with glucagon is instilled to open up the papilla and flush out the stones. Then a basket can be passed over a guide wire, or a Fogarty can be used to extract. And a choledocoscopy is done to check clearance. And it is a simple procedure with rapid return to activity. In transductal, the CVD is opened up and it can be closed either primarily or through an internal stent, or maybe closed over a T-tube. So how I do it, the cystic duct is usually large in size, it's dilated, so it needs a hemolock or transfixation with a vicryl suture. The CBD is cleared of the peritoneum and then it is cut with either a hook diathermy or a micro knife needle scissor. The CBD is opened and a choledocoscope is passed to check for the stone. The stone is removed by a mechanical method. And sometimes it needs lithotripsy to break down the stones and take them out. A post-choledocoscopy clearance to make sure the patella is clear, proximal duct is clear is again checked, and then it is closed over a T-tube, and a T-tube cholangiogram is done to make sure the distal is clear, the bile duct flow is good. Few complications like in any other surgery can happen, but with adequate technique and by being careful, all can be avoided, like CBD laceration, stricture formation, and bile leak. Post-operative complication occurs in elderly, and this disease also affects the elderly. So some of them may be very elderly and frail patients. So in them, time is a factor. So for them, I choose that if it is going to be a long time doing a CBD exploration, I'd rather do a quick open cholecystectomy and CBD exploration and save them many post-operative complications. It needs a bit of surgical expertise. So once one has done a 200, 300 lap choles and have suturing experience, they can go ahead and do this. A laparoscopic biliary surgery is now safe, it is efficient, it's cost effective, and it results in successful clearance. Open CBD is the procedure when other methods fail. ERCP is the most commonly used procedure, but it has two persistent problems. There is failure of cannulation, and post-operative pancreatitis can occur in 5 to 8% of the patients. And late effects of sphincterotomy has been seen, like recurrent cholangitis, pigmentous stones, and very rare incidence of malignancy over a 20-year period of time, which also occurs after any other biliary enteric anastomosis. So in this, a cholangiogram is done, the stone is extracted. Comparing lap CBD with ERCP, one thing is notable that in lap CBD exploration, there is no evidence, there is no incidence of acute pancreatitis. To conclude, CBD stones before, during, and after cholecystectomy have different treatments. You have to treat the patient individually and design the treatment depending on the patient. It depends on the stone number and size, the size of the CBD, the past surgical history, the surgeon's experience, and ultimately it has to be tailored to the patient. A minimal access surgery should be minimal trauma also. So this one should make this clear, especially when dealing with elderly patients. To do a quicker procedure is better than doing a very lengthy operation. And ultimately, it is all about teamwork, so everybody knows what to do. And when the mechanical retrieval is not possible, then somebody goes and does the lithotripsy for me. My anesthetist helps me with the choledocoscopy, and I have a team. So it can be done smoothly, safely, in a very quick time, and with very good results. Thank you.
Thank you, Dr. Sanjay. I think I will accept whatever you have said. I don't have any question, but I will ask Dr. Vijay Mittal if he wants to.
No, I think in the interest of time, we will skip the questions for now. Thank you. Very nice presentation, Sanjay.
Thank you.
Thank you. Very comprehensive.
Thank you, sir. Next, I will call Dr. Gaurav, Senior Consultant, Medanta Hospital, Patna, for a CBD injury. What now?
It's my pleasure to introduce Dr. Gaurav, He is an experienced surgeon in advanced laparoscopic surgery and in upper and lower GI oncosurgery. Having done his DNB in general surgery, he specializes in laser proctology, laparoscopic colorectal surgery, hernia, and other basic surgery. Performed more than 1,000 laparoscopic cholecystectomy and more than 50 Whipples, more than 150 upper GI oncosurgery. He is at present working as a consultant at Medanta, Patna. And he is going to talk to us about what happens once you have a disaster in the table while doing cholecystectomy and you see bile. Dr. Gaurav, please.
Thank you very much, sir, for this kind introduction and giving me this opportunity to say something about CVD injury. So my presentation is basically divided into 3 parts. Whenever a laparoscopic surgeon is doing gallbladder laparoscopic cholecystectomy, they have that fear to have a CVD injury. And I think no surgeon can say that they would never had a CVD injury in their life. So this is a very important topic for surgeons, and whenever a surgeon have a bile duct injury, there is a panic in the mind. Probably the surgeon is not showing that panic, but still that panic happens in the mind. And what to do when you have a CVD injury intraoperatively or have a CVD injury patients post-operatively day 6, day 7, or you might have a biliary stricture after a laparoscopic cholecystectomy after say 2-3 months or say 2-3 years. So laparoscopic cholecystectomy is the most commonly performed minimal invasive surgery in India and in our part of the world. And this is the currently standard procedure for all gallbladder stones or acute or acalculous cholecystitis. And incidence of bile duct injury in open cholecystectomy is 0.2 to 0.3%, and in laparoscopic surgery it is slightly more, 0.6%. And first of all, how to avoid a bile duct injury performing a cholecystectomy. So identification of anatomy is important, and then while doing gallbladder laparoscopically, retraction of the gallbladder is important, how a person or a surgeon is retracting the gallbladder from the fundus and from the Hartmann's. And then the critical view of safety, the importance of critical view of safety is very important, how you see a cystic duct and artery while doing it. And then bile duct timeout, this is very important. While we dissect callots, after dissecting, when you are going to clip, there should always be a timeout, and that is you have to see the bile duct properly, enteric position of the duodenum, and then sulcus of Rouvier, where hepatic artery is, and then umbilical fissure, and you may have a camera out and think about the anatomy and do the clipping. So bile duct injury can happen to any surgeon. It may be due to misidentification of common bile duct with the cystic duct, or aberrant right sectoral hepatic ducts, or maybe difficult gallbladder, difficult callots, frozen callots, or maybe injudicious use of diathermy, or use of diathermy during bleeding, or use of clips during bleeding. So this is an example of a biliary duct injury with an aberrant biliary anatomy. So suppose you are doing a cholecystectomy and you detected bile. So this is one scenario, that is bile duct injury happening intraoperatively. So what to do then? First of all, I want to emphasize that a surgeon should maintain its calm. They should call for help. Whosoever is available in your vicinity, call for help, and then think about it, what had happened, how it happened, and then if you have armamentarium for intraoperative cholangiogram, please do an intraoperative cholangiogram and try to identify the biliary anatomy. If suppose you are not able to identify the biliary anatomy, please don't do a laparotomy. If you are going to do it, you may cause more harm. So please don't do laparotomy. If you are unable to identify the leak, or if you are unable to identify the injury, or if you are unable to identify the extent of injury, then please put a drain and send a patient to a better place, to a place where expertise is there and they are dealing with biliary duct injury on a regular basis. So these are the few pictures of intraoperative cholangiogram, and as I have said that there are 3 scenarios for the biliary duct injuries, and this is the classification of biliary duct injuries. I have to hurry, so I am skipping all this in detail. Say injury to bile duct is usually recognized during the procedure in 25 to 30% cases. If you are confident enough that you can deal with this injury, then proceed. Or if you are not confident enough, or if you are not doing hepatobiliary surgeries on a regular basis, then please put a drain and send the patient. At least a drain will save the patient with all those morbidities and the psychological difficulties a patient have with bile duct injuries. So do not dissect further either laparoscopically or do not convert to open. Put a subhepatic drain, counsel the relatives, and after patient is out of anesthesia, please counsel the patient as well. This is very important. Write the notes properly, what had happened during the surgery, and try to help out the other surgeon who are going to fix it for you in a later period. That OT note, the operative note, will help the surgeon who is going to fix it in near future. So paperwork and counseling is very important. If you think that you can repair this, then you can proceed for immediate repair. But I would always suggest that do it with some help. So for repair, size of bile duct injury is important. If the duct is less than 3 mm, or if intraoperative cholangiogram is showing that it is draining one segment or a sub-segment, simple ligation is can do. If the duct is more than 4 mm, or if it is draining multiple segments, then you can think of operative repair. So for operative repair, circumference of the injury is important. Injury by electrocautery, which involves less than 50% of the circumference of wall, you can put a T-tube through the injury and helps in healing with bilioenteric anastomosis also. And if injury is by electrocautery and involves more than 50% of the wall, resection of the injured segment and anastomosis to re-establish the bilioenteric continuity, you can do Roux-en-Y hepatico-jejunostomy. If the length of the bile duct injury is less than 1 centimeter, you can think of end-to-end anastomosis with a T-tube placement, or if the injury is more than 1 centimeter, then avoid end-to-end anastomosis, debride the proximal end and do a Roux-en-Y hepatico-jejunostomy if possible. Then suppose a patient is presenting in post-operative period day 6 or day 7, and patient might present with pain abdomen, distension of abdomen, fever, features of cholangitis with jaundice. The first thing what we need to do is that we have to stabilize the patient with IV fluids, with antibiotics, and then investigate accordingly to know the extent of injury. And investigation might be with MRCP or intraoperative cholangiogram, or you can do PTC and then investigate. Then after controlling infection, limiting the inflammation, you can go for re-establish the biliaroenteric anastomosis with Roux-en-Y hepaticojejunostomy with tension-free mucosa to mucosa anastomosis and long-term transaortic stent if bifurcation is higher. If patient is presenting with stricture, then also you can investigate the patient accordingly with MRCP and then plan according to the type of injury. Most frequently what we do is Roux-en-Y hepaticojejunostomy with 4-0 or 5-0 delayed absorbable monofilament sutures with placement of trans-anastomotic stent and with a drain to control the leak. Then something about the medico-legal aspects of biliary duct injury. Injury to the bile duct is an accident. To miss the bile duct injury is a mistake, and if you are mismanaging it, then it's a negligence. So the last line is important. We have to know how to manage it. If we are not expertise to do that, we can refer the patient to a center where hepatobiliary surgery is on regular basis. But don't try to mismanage because it can lead to you in a sue. And documentation is very important, as because operative note will help the surgeons in future. Thank you so much.
Thank you, Dr. Gaurav, for a nice summary of CBD injury. Actually, it's a very vast topic. It can be divided into acute, chronic, and intraoperative, postoperative. Lots of things are there. But within 10 minutes, it's not possible to cover all things. But congratulations, you have covered almost all important points. We can discuss further, or for the sake of time, I think there's already 1.5 hour delay. So, any questions from audience? Otherwise,
we can take one question.
If there is no questions, then thank you very much.
Thank you so much. Thank you.
टॉपिक नहीं मिल रहा है क्या?
नहीं मिल गया सर, आपको मिल गया सर, बोले।
Next, I will like to call Dr. Avinash Kumar, Senior Radiologist from Medanta Hospital, Patna. Topic is role of interventional radiology in the present era of clinical practice of medical and surgical gastroenterology. Thank you.
कैसे करना है, आगे बढ़ाना कैसे? अच्छा, ऊपर नीचे से नीचे करना है, ठीक है। Very good evening to everyone. I am Dr. Avinash, practicing intervention radiologist in Jayaprabha Super Speciality Medanta Hospital, Patna. Today I'll be talking a bit about the role of recent advances in intervention radiology in the present era, clinical practice of medical and surgical gastroenterology. And as such, the topic itself is too vast. It's very difficult to cover the entire topic of role of intervention radiology in the present era. But I'll be talking about and showing you some cases which we have done in a recent short period of time for our gastroenterology patients. I mean, intervention radiology takes care of various variety of medical and surgical gastro patients, ranging from liver tumors to liver infections, liver transplant and its complications, portal hypertension, cirrhosis, acute GI bleed, and the list is on and on. So it's entirely impossible to cover the entire topic of a role of interventional radiology for our GI patient in such a short period of time of about 10 minutes. So let's see some cases what we have done in a short span of time in our hospital. And during that discussion of that cases, I'll be discussing about the various aspects of the patient's conditions, as well as why we did this case and what were the thought process behind doing this intervention procedures in such cases. So, this was a case of a septic pyogenic abscess. Now, word side can be treated many ways, but you know that the size of this pyogenic abscess was somewhere around 5 to 5.5 centimeter. For doing an PCD placement, if any patient to you who comes in a sepsis with a larger pyogenic or hepatic abscess, and if the fever is not subsiding, patient is in sepsis, it's always advisable to put a PCD. Not only it takes out the pus content, the necrotic content, and the infectious content out of the body, it will help the patient to regain its normal status as soon as possible. For these cases, generally we plan the patient on an either emergency basis, or we can take it for an empirical treatment. We generally ask the patient to undergo a simple blood test, which I'm sure all the patients who are admitted with this kind of a disease must be having that. We just make sure that the patient is having a normal viral profile and coagulation parameters. We make sure that since we are putting almost 10 or 12 French pictal drainage catheter through the liver, we want to be doubly sure that that patient's coagulation profile is within normal limit. Preferably INR should be less than 1.5 and the platelet count should be at least more than 50,000 to proceed with these cases. If not, we can correct the coagulopathy by giving vitamin K. Now, the second case was referred to me by our surgeons, and it was a known case of some benign biliary stricture, but patient was in sepsis because of the moderate ISB dilatation, and the cross-sectional images showed multiple cholangitic abscesses in the liver, and patient was really in a bad state. The surgeons wanted us to put a PTBD and some sort of external drain for the sepsis to be controlled. And I would like to talk a bit about PTBDs. When do we do these PTBD cases? PTBD can be done in benign biliary strictures, can be done in malignant strictures due to, particularly in our region of the country where cholangiocarcinoma and GB malignancy is very much prevalent. We can do to relieve the obstructive jaundice in such cases where the operation is not feasible. We can relieve the patient's pruritus, we can relieve the obstructive symptoms of the patients. And sometimes these patients, due to obstructive jaundice, may present with cholestatic abscesses, and these patients will be really very sick. Forget about cancer, he will die of the sepsis itself. So, PTBD is a boon for such kind of a patient. The idea is to always give some access of the bile duct. Even if you cannot drain the bile duct internally, at least we try to drain it outside so that the patient's overall condition improves. And to some extent that, his total bilirubin will come down to a range of somewhere around 2 to 3, where our medical oncologists can take them up for chemotherapy if it's a case of a malignant obstructive jaundice. Or in a cases like this where it's a known case of benign biliary stricture, just to bring down the total bilirubin and relieve the patient's symptom of the jaundice is helpful. Here in this case, I wanted to cross the stricture and put a plastic stent, because plastic stent can be easily placed in a benign biliary stricture, and not metallic stent is not recommended in benign biliary stricture. I always wanted to cross the stricture and put a plastic stent. However, because of the massive edema, I could not cross the stricture. The only thing was left to at least drain the patient's bile outside. So I left a 12 French pictal drainage catheter and was draining the whole bile outside in a Eurobag. Luckily, and we sent him home with this external drainage catheter. After 2 to 3 weeks, when patient improved, sepsis settled down, surgeons have taken this case for benign biliary stricture. Biliary repair. This another companion case, but instead of a benign stricture, this was advanced. It is a case of advanced gallbladder malignancy with obstructive jaundice. So again, here in the same scenario, patient was not fit for surgery, not operable for GB malignancy, and his jaundice was increasing. Total bilirubin level was increasing, direct bilirubin count was increasing. Patient was having some sort of cholestatic jaundice, and so medical oncologists have asked me to do a PTBD to relieve the obstructive jaundice, at least to extend that patient's life, quality of life till he survives should be improved. Or in the best scenario, we can bring the total bilirubin to a level of 3 where chemotherapy can be started for him. Unfortunately, this patient had a lot of financial issue. So in this case, I could cross the malignant stricture and I put an external internal ring biliary drainage catheter here. Now this ring biliary drainage catheter is a very typical type of a catheter. It has multiple holes just above and below. So that you have to put you have to adjust the catheter in such a way that you put proximal holes above the level of obstruction and some distal holes below the level of obstruction, so that it will help the patient to drain the bile both externally as well as internally. But there's always concern that if you try to drain the bile outside, it is not completely good for the patient metabolically, because patient will lose a lot of minerals and the patient will get dehydrated. So once we put this external internal biliary drainage catheter, we allow the external drainage catheter for a 1 day and we see how his bilirubin is reacting. If his bilirubin is towards the downward trend, we know that the patient condition is going to improve. We cap it. We cap the external drainage catheter. Again, we wait for 24 hours to 48 hours. Again, we see whether the total bilirubin count is going down or not. If the total bilirubin count is still going towards downward thing, then we know that patient has been able to drain its bile through the internal drainage catheter. So we can just cap the whole external thing and paste it on the patient's skin, and patient can be discharged. In this way, he doesn't have to carry a Euro bag alongside with him during his day-to-day practice, day-to-day work. I've asked this patient to come back after 2 weeks for a metallic stenting, but the patient did not turn up, probably because of his financial constraints. Another companion case, this was a young chap, unfortunately, with advanced gallbladder malignancy, with multiple extensive liver metastasis in the liver. He was having both component of obstructive as well as the liver failure kind of a scenario. So again, the medical oncologists have asked me to, can we do something about for him? So if in this case, again, I could cross this malignant stricture and we have put a metallic stent here. This kind of a stent is a self-expandable metallic stent. It has a very good radial strength. It will go through the malignant stricture. It will, I'll just go it for. It will dilate the stricture and it will stay like that only. Unfortunately, this stent has a lifespan of somewhere around 6 months to 1 year till the ingrowth from the malignant stricture malignant part will come through the stent and may occlude it. But even if it gets occluded and the patient is still alive, we can put a re-stent within it. Here you can see I put a metallic stent here. This is the metallic stent. You can see it in the fluoro images. And I put external drainage catheter for a day. Once I'm sure that this SEMS is working properly, then I can remove the external drainage catheter and patient can be sent home. Okay, now another set of study we have done. This was a young boy with I met with an RTA presenting to us somewhere in the late evening, and patient was hemodynamically unstable. CT angiography was done, and CT angiography showed a leaking pseudoaneurysm from the right hepatic artery branch, and you can see a large laceration in the adjacent part of the liver. We always prefer to do, whenever a patient comes to you with a hemodynamic instability, please do not hesitate to ask for a CT angiography. CT angiography does not delay your time. It hardly takes little bit of your time, but it gives you a lot of useful information, like what exactly is going on, where is the exactly bleeding point, what are the other injuries patient has suffered, and how can we plan this? Whether should we send it for surgery, or should we, or should I do something? Endovascularly. There's so much information CT angiography can give you. So please, it's my sincere, request to all my physician colleagues, do not hesitate. Even if the patient is unstable, if he can be taken, please, advise for CT angiography. here in this case, we did the CT angiography. We could find the leaking pseudoaneurysm from the right hepatic branch. We did the angiography, and angiography images, catheter angiography revealed there's a leaking pseudoaneurysm, which was approached with the help of a microcatheter. Again, check microcatheter injection, confirm the pseudoaneurysm, and it was embolized using a permanent embolic material, which is called as liquid embolic agent, medically called as medical glue. And it's called, its original name is N-butyl cyanoacrylate. Like this, we have plethora of embolic materials. We can use coils, we can use PVA particles, we can use gel foam, we could use, stent graft, but here in this case, I could have used both particles as well as coils, but here in this case, we treated this patient using NBCA glue. Patient did fine, hemodynamically he improved. Another companion case, this again is a young chap, RTA, came with hemodynamic instability, and we did CT angiography. CT angiography revealed AST grade 3 liver injury and a pseudoaneurysm again from the right hepatic artery branch. Now here the catch was there. This hepatic artery was not originating from the celiac plexus, it was originating from the SMA. Now this is the beauty of CT angiography. Had I taken this patient just based on the gut feeling that, obviously there's some pseudoaneurysm will be there, I will straight away take him to the cath lab, I will not know where the bleed exactly is coming from. So this CT angiography told me that the bleeding source is hepatic artery, and instead of coming out from the normal celiac plexus, it's coming from this SMA. So it's a replaced right hepatic artery. Now it's a brilliant and a very useful information for me. So I can plan my angiography, I can plan my hardware for intervention radiology, I can plan my embolizing material based on this much bit of CT angiography information. So I knew that I have to hook the SMA to get into this right hepatic artery. I did the same thing. Contrast was given, pseudoaneurysm was confirmed, it was approached as close to the pseudoaneurysm. Here again I used the NBCA glue to embolize the material. Patient did fine, hemodynamically he improved. Again, another, this was one of the first case I happened to get, I had joined, I think 7 to 10 days in the Medanta hospital, and one day I got a call in the night that a patient is there. I think Dr. Abhishek could remember this case, and he had only told me to, he had only referred me this case, and this was again a young chap, and again CT angiography was done. It showed AST grade 4 liver injury. The black area which you are seeing is all the lacerated liver, and the central white dot is the pseudoaneurysm which is leaking. So CT angio showed the same thing, and again it was arising from the anterior segmental branch of the right hepatic artery, which was confirmed on the catheter angiography thing. So we could approach the exact feeder of the feeder vessel through the use of a microcatheter, prograde microcatheter. Check angiogram, confirm I was at the exact site of the aneurysm. Here I used microcoils to embolize this material, and here I had to put a coil extending from distal to the level of the pseudoaneurysm and keeping it to the proximal level, so that it's called trapping method. So that even if I put a just coil there, the aneurysm will start filling from the contralateral side. So for that to stop, I have to block his input as well as the outflow. So this is called trapping method of treating a pseudoaneurysm through the endovascular way. Again, this patient did well and got discharged in a hemodynamically stable condition. This is again a slightly unusual case. This middle-aged old lady was having a recurrent abdominal pain. She had gone to a local gynecologist somewhere outside, and she had asked to undergo an ultrasound for the evaluation of the abdominal pain. And ultrasound had picked up a large cystic mass lesion in the liver, for which she was referred to a Medanta team for the further management, and it had gone to surgery. So they had asked for a CT abdomen triple phase, and on CTA we could see this is a giant liver hemangioma. You can clearly say there is a tuft of vessel all around the periphery of this large cystic lesion, which is characteristics of giant liver, liver hemangioma. So generally we do not do anything. The liver hemangioma is an incidental finding. We don't need to do anything. But unfortunately in this case for this lady, it was a giant liver hemangioma. It was measuring somewhere around 14 centimeter. This much big giant hemangioma is always prone to it's always prone for a rupture, and a patient may rupture and may bleed anytime. Even if she hits, blunt injury of trivial nature could have ruptured the entire giant liver hemangioma, or the patient would have gone for consumption coagulopathy. So, surgeon had referred this case to me for prophylactic embolization. I counseled the patient, I told them the scenario, I told them you can go back and you can observe, but there's always a risk that, this pain will be there because of the capsular stretching of the liver, or it may get rupture on its own, and in that case, it will be extensive bleeding. Earlier, people used to do embolization prior to the enucleation of the giant liver hemangioma by using PVA particles, but in this case, I had used a slightly different technique. I used a antineoplastic drug called bleomycin to treat this thing. Recent papers have come where they have shown the effects of bleomycin and a lipid oily material called lipidol. They mixed a combination of bleomycin and lipidol, and they actually showed it that even if you just embolize this giant liver hemangioma and you can follow it up at a matter of 3 months, 6 months, 12 months, you can actually see the shrinkage of the overall size of this hemangioma. Just 1 sec. So I did this, patient was fine, and patient got discharged till now, and the overall size of the hemangioma has reduced from 14 to 12 centimeter in the matter of 6 months. So I don't have the picture of that. So, it was just a taste of all the different kind of intervention procedures we can do for our GI patients. So the take-home points are intervention radiology procedures are a very useful tool to have for all types of medical or surgical gastro patients. It is minimally invasive in nature, does not cost much. You cannot say, no procedure in the world is complication free, but definitely has lesser risk of complication. Thus, patients are friendly. Patients are happy, doctors are happy, attendants are happy, everybody is happy. And cannot stress more that, indications of IR are ever and ever growing in all the specialties of medicine. Thank you.
Thank you, Dr. Avinash, for nice presentation. For your session, ex-professor, head IJMS, well-known gastroenterologist, Dr. B.K. Agrawal sir is here. Please, sir, have few words, sir. Please.
Thank you.
Dr. Avinash has given a nice presentation of interventional radiology, and many times when we are finding difficult to do endoscopic procedures in bile duct or other situations like GI bleed and all that, we take help of radiologists, and they are doing their job well. So, but I will say that given the chance of dealing with patients where endoscopic management is possible, I think that is first right, because it is less invasive than radiology.
Definitely. In case of obstructive jaundice, if you find that if the obstruction is below the level of hilum in the distal CBD, ERCP is always possible.
Definitely.
I always ask them to undergo a ERCP, but if it's a proximal obstruction,
that becomes difficult.
In that case, PTBD is more preferable.
That's difficult. Thank you.
Thank you.
Thank you, sir. Now I would like to, for the felicitation, I'd like to call Dr. Sanjay Kumar, speaker, Dr. Gaurav Kumar, Dr. Avinash is with us, and I also like to call the chairperson for the session, Dr. K.N. Sinha sir, Dr. Vijay Mittal sir, Dr. Ramesh, Dr. Utpalanan, and Dr. Alok on the dais. I'd like to call Dr. B.K. Agrawal sir. Please felicitate. Dr. Alok का है. Dr. Alok उधर है. Dr. Alok. Dr. Vijay Mittal sir. Dr. K.N. Sinha sir. Dr. Sanjay, sir. Dr. Utpal Anand. कहाँ निकल गए? अच्छा, Dr. Ramesh sir. So Dr. Ramesh will take the Dr. Utpal's memento.
For letting him go.
Dr. Gaurav. एक ग्रुप फोटोग्राफ डॉक्टर speaker Dr. Avinash. Sir, please, Dr. Avinash.
After group photograph.
Acha, after group photograph. Dr. Avinash. I am requesting K.N. Sinha sir to felicitate Dr. B.K. Agrawal sir.
Who is going to do that?
Just for a while, sir. Just for a while.
We did not expect him to put one ending with one head.
न्यूरो या न्यूरो वाले से शुरू करेंगे।
So, last but the most important, our body can't move without brain. So next few sessions are for neurosciences, and the first session is recent trends in neurosurgery. For that, I would like to welcome Professor Dr. A.K. Agarwal, who has been ex-Vice Chancellor, Aryabhat Knowledge University, and also the ex-HOD of Patna Medical College and Hospital, and Professor Dr. Samrendra Kumar Singh, HOD IGIMS Neurosurgery. Please, sir. Please have a seat. Dr. Mukund Prasad, sir, please. Dr. Mukund Prasad, sir, is the Director of Neurosurgery at Jaipur Medanta Hospital. Please welcome.
Hello. Hello.
Hello. At the end, I was surprised to get that information from our management that the brain is at the end of things. Sir, it's at the beginning of everything, and it's pretty lonely out here. But to cut the nonsense from my side, I can only say that neurosurgery happens to be at the cutting edge of the ever-expanding frontiers of medical knowledge, be it the operation theatre cluttered with highly digitalized reality-augmented neuronavigation, or be it endovascular, or be it robotic surgery. It is my great pleasure to introduce Dr. Mukund Prasad, who is a master of all these things. Dr. Mukund did his MBBS and MCH from Banaras University in the year 2004, and then he went on to do his postdoctoral fellowship from in vascular microneurosurgery from Sri Chitra Tirunal Institute in Trivandrum. Thereon, he went on to join as a consultant at the Amri hospitals in Calcutta, and then he joined Paras HMRI Hospital as its director of neurosurgery from 2013 to 2021. Thereon, he went on to join the Jayaprabha Vedanta Hospital, where he is now in October 2021 as its director in neurosurgery. He started vascular neurosurgery in Bihar and does lots of complex brain tumors. I am witness to that. And he also has been given the Times Health Neurosurgical Care Award in 2018. Over to Dr. Mukund Prasad. Mukund, carry on.
Pardon me for your time. Pardon me for your time. I would also like to call upon the stage Dr. Ajay Kumar Singh, former director IGIMS, Dr. Nitish Kumar, neurologist, and Dr. S.M. Rahatgi, the neurosurgeon. Please, sirs.
We cannot do without. Sir, without you talking in us, we cannot do it. Sir, after
Thank you, sir, for the kind introduction. I will not take much time. As you said, neurosurgery is at the cutting edge. And to start with, Wilder Penfield, as most of you know, he was instrumental in defining the motor and sensory homunculus. He defined the functional areas of the brain, and he said, made up of a dozen billion microscopic nerve cells, units interconnected by millions of
conducting nerve threads weaving incredibly intricately, forming patterns in the brain, and brain as an object of research presents a defiant challenge to its own ingenuity. मतलब ब्रेन जो है अपने आप को ही समझने में अभी असक्षम है. Neurosurgery is still at the periphery because we can make structural changes, but we cannot make interconnections, we cannot create intelligence, we cannot create consciousness. So with this, I'd like to present a few cases. So recent trends in neurosurgery, recent advances that have occurred in neurosurgery are neuronavigation, awake craniotomy, endoscopic neurosurgery, neuromonitoring, minimally invasive spine surgery, functional neurosurgery, and stereotactic neurosurgery. All these armamentarium, they are designed to inhibit or minimize injury to the brain when we try to get rid of the diseases that afflict the brain. So coming to neuronavigation, this is a 60-year-old man who presented with progressively increasing weakness of the left side of the body, and on imaging we found a large abscess, and this abscess was abutting the motor cortex, and as you can see here, so neuronavigation helped in planning the trajectory to this abscess without damaging the motor cortex, and immediately after the surgery patient regained some of the power, and after 1 month he was able to stand and do work with both hands normally. And this is the post-op scan. As you can see, there is minimal blood just behind the motor cortex, which is you can identify on by the omega sign here. Next is awake craniotomy. That is also in the armamentarium of neurosurgeon with the help of neuroanesthetists who keep the patient awake so that we can assess the function of the patient during surgery. And at the slightest hint of any disturbance in the function, we stop the surgery. And similar was the case with this young man who was having intractable seizures, and he was found to have a low-grade glioma just in front of the motor cortex. So he was kept awake during the surgery for the resection of the tumor, and at the posterior margin of the resection, the patient has started complaining of weakness in the lower limbs. So that is where the surgery was stopped, and it has been 3 years. The patient is free from seizures and free from any recurrence of the tumor. Endoscopic surgery is another tool. Now here is a patient who had asymmetrical hydrocephalus, and there is a small lesion at the foramen of Monro. Here, endoscopic view shows there is a colloid cyst. This is the video, this is the endoscopic view. The cyst has been fenestrated, the colloid material is being taken out, and the foramen of the rest of the capsule is coagulated, and foramen of Monro is dilated. This is a post-op scan showing resolution of hydrocephalus, and the patient is well. Another case recently, a young lady with pregnancy, precious pregnancy by IVF, she developed cerebellar hemorrhage with resulting hydrocephalus, and she was becoming unconscious because of this hydrocephalus. So we took her for surgery, that is endoscopic third ventriculostomy under local anesthesia. We could not operate upon her on the cerebellum because she had to be put in prone position, which was contraindicated because of her pregnancy. And this is the immediate post-op scan, and the MRI that you are seeing in the end is after 1 month, and here you can see a beautiful fenestration and CSF flow through the floor of the third ventricle. Young patient who had vision problems treated by steroids, and suddenly he developed ptosis of left eye and loss of vision in the right eye. Endoscopic pituitary removal caused improvement of the ptosis, but right eye vision did not improve. Now neuromonitoring. Neuromonitoring is monitoring of sensory motor evoked potentials in defining or maintaining the integrity of the neural structures, especially the cranial nerves, or defining the sensory motor cortex or brainstem evoked potential during surgery. This is the surgery for acoustic neuronoma. This is a large acoustic neuronoma where we operated. This is the end part of the surgery where tumor is removed, and then the nerve, seventh nerve, could be identified with the help of nerve integrity monitor. And as you can see, this is the nerve here after the tumor is removed. This is the seventh nerve that has been identified and preserved beautifully with the help of nerve integrity monitor. And as you can see in the clinical photograph, there is very slight facial paralysis only on effort, and on rest there is no deviation of the mouth. This is a young boy, 7 years old, who presented to us with gait unsteadiness and headache. And as you can see, there is a very large tumor occupying the posterior fossa, extending into the upper cervical spinal cord. And this looks frightening. We operated upon the whole tumor, and during the surgery we employed the use of somatosensory evoked potential to identify, because the brain stem as well as the medulla and spinal cord, they were paper thin, and in the post-op scan you can see that there is very minimal residual tumor. The boy is neurologically intact without any problems. It came out to be grade 2 ependymoma, and the patient is on radiotherapy. Another lady with bitemporal hemianopia, loss of vision, and as you can see there is a suprasellar tumor that is pushing both the optic nerves apart widely. And this is the post-op scan where you can see the tumor has been removed. The pituitary stalk is preserved. Patient did not have any post-operative DI or electrolyte imbalance. And these are the two perimetry field of vision charts that is showing significant improvement in the hemianopia. Another case where somatosensory evoked potential is used to identify the deeper structures. This is a large insular glioma, grade 2, operated with minimal residual, and the depth of the tumor, internal capsule, was identified where surgery had to be stopped for fear of causing hemiparesis. Now, minimally invasive spine surgery along with disc, minimally invasive fixation for spinal fractures. This is one interesting case where the patient came with severe back pain, and he had a large epidural abscess extending right from cervical spine to lumbar spine. So with the help of tubular retractor in the cervical region, the abscess was drained, and this is the post-operative scan where you can see the MRI is showing that there is complete resolution of the abscess and the patient was well. Then coming to 3D printing, this patient with a very large complex defect in the skull after road traffic accident had a prosthesis made of polyethyl ether ketone printed by 3D technique, which has made almost normal looking contour of the head. And this is the post-operative CT scan where you can see the staplers also still visible, and the resulting cosmetic appearance is very beautiful. So these are some of the cases. Future trends: artificial intelligence, image analysis for most of the tumors, where artificial intelligence can analyze thousands of images, their characteristics, location, help in planning trajectory, help in prognostication, help in even typing the type of tumor, and in future they can also lead to automated intervention, either self-regulated or guided by the surgeon. Nanotechnology for delivery of apoptotic genes. As we know that for gliomas, high-grade gliomas, the prognosis is still very poor. Median survival is only 5 to 8 months even after best of treatment. So novel methods of drug delivery, targeted gene therapy is being tried with no avail. But yes, we have some direction. Then nanorobots, which can be guided by the surgeon, which can go inside the vessels, help in opening up blockages in the arteries for prevention and reversal of a stroke. Nanotubules and scaffolds to augment regeneration of nerves for acute nerve injuries or even spinal cord injuries. Thank you.
we'll cut short our discussion. Anybody wants to ask any questions? Aplo? Ajay, you want to ask anything?
Hello. Very nice, and in a nutshell, he has covered almost all the current advances in the management of neurosurgical patients. With time, as we are growing up, we are becoming more and more safer compared to about 30 years back or 50 years back when neurosurgery was just a butchery, I will say, at this stage. So in future also we will have more experiences, more techniques to improve upon the care of the patients. And that additional points can be in the coming future we may have exoscopes also, and we may have robotic surgeries which are coming up with the neurosurgical armamentarium. These two are additional new gadgets which will help us.
Can I ask you a question?
Yes,
I hope I'm not encroaching too much in your time. Just one question, for my knowledge sake only. What is the current status of genetic decoding and genetic therapy of, the malignant gliomas you're talking about? What is the current status, not the book knowledge, in our country? Can you go about it?
In our country, I don't know, but yes, definitely a lot of trials are going on, and multiple phase 3 trials employing various techniques like chimeric antigen receptor cells, cytokine therapies, and even viral vectors. They have been tried in phase 3 trials without any significant benefit shown. But yes, trials are underway for to see whether they will be helpful in future.
Thank you very much.
Sir.
I don't need a mic, as you know. All this time I've been hearing your prayers. So I just want to applaud what a wonderful presentation it was. One question I would ask along the lines of what, sir, you have said. Do you consider stem cell surgery or that class of surgery as a different to everything that you have shown, which is very quick to understand? Or does it fit into any of the groups that you
No, stem cells is being tried, sir, but as I said, the only my personal view is stem cells, as I understand, I don't have much knowledge, but stem cells, they have the ability to regenerate into the tissue where they are where it is targeted. But my only thing is, tissues you can make, stem cells can go and proliferate there, but how do you make connections between these neurons for a meaningful network? So that is where the hindrance lies. When an embryo develops and brain is developing in utero, the connections are made based on their genes and depending upon what personality the parents have. But once a damaged brain, you put stem cells and allow them to regrow, what will be guiding them to make a meaningful network? It is just like throwing electronic components together, mixing them up and hoping that they make a useful circuit. So that is where the difficulty lies.
Can I add a point to that? That was a very interesting question. The stem cells at the moment, they have a very good characteristic, unrealized, we cannot know why, that they are able to home in at the site of the lesion. They have a tremendous homing capacity. If you give an intravenous dose of stem cells, they will home into the correct place. The question lies 2 or 3 points. They have been tried in neuro head injuries. They have homed in, they have formed neurons, but the functional capacity, as Mukund just said, is unknown. They do not function. Similarly, it happened in spinal cord injuries. They have not been able to cross the site of the lesion. They grow above and grow below, but yet not able to cross the site of the lesion. So there is no question of any functional recovery there. So the functional aspect of stem cell therapy is still yet to be established.
Yeah, in fact, if you look at it, brain controls the whole body, and basically you can divide, it's a little off from the books, where they need a pointed information. That means I want to say something which should reach only Mukund and it should not reach the Samrendra. Then the nerves. When I want to make a news announcement to the whole hall, hormones. They control through the hormones. And I do not want to interfere, something T is going outside. I do not interfere day to day. Only in between I do some checking, like the heart keeps on beating without much, with a limited control, but it does not survive once the brain support is gone, beyond certain time. And the problem is that these are not interchangeable. When you put something from outside, and if its function is of a second category, like if you go for a general announcement, maybe it releases some hormones and it may work. But when you need a focused one, problem is that I want to send a message to the Mukund, but it reaches Samranda. And it can be, so I want to develop extension, it may go into the flexion. So it goes to the other way. And the problem of this connectivity, gaining a connection, that's something where there have not been a meaningful advancement. That's one. Then I think, Mukund, there are some other field also where you collaborate with your neurology colleagues, like deep brain stimulation. A lot of things are going on there. Possibly you are less interested because that's you operate and then it's captured by the neurologist. And there are certain other areas which is advancement, basically not in your field, but they are trying to take up some of your loads. And that they have been talking the intervention and so-called gamma knife and other. It's no knife, but that one. So they are trying to eat away from your share. That's one. So I think, but deep brain stimulation but there are also a lot of things going on in your territory.
Yes, sir. Deep brain stimulation is there, but what we
It's
are...
a very vast field, Mukund.
Yes, sir.
And it's impossible to cover
But,
the recent...
I think,
as I said, the recent advances occur every day. Like the changing models of a TV, it is faster than that. It's impossible for anyone to keep pace. Therefore, it's impossible for this poor fellow to be so much up to date. So I think we should close the session because others are waiting. Thank you very much.
Thank you for the wonderful job, wonderful summary in a short time. And it's easier to speak for 1 hour than to speak for 10 minutes. And they have put that to you on that. Okay. Thank you. Wonderful job.
Thank you.
Wonderful.
So that wonderful question reminded me of a novel called Da Vinci Code of Dan Brown, that stem cell in neurological diseases. So let's move on to next session, and that is by Dr. Deepa N.A., and she will be presenting thrombolysis in acute ischemic stroke. I have been directed to introduce her as well. So Dr. Deepa N.A. is a DM neurology from NIMHANS, Bangalore. As a colleague, I would say that she is a very humane neurologist and very good neurologist, at par with I won't say the best, but yes, maybe top 10 neurologists in India. And one more thing that I would like to add, that she is the daughter of Bihar as well as Karnataka. Thank you.
Yeah, I think Deepa, she's a bright neurologist, and we have here, better half of the here, and possibly, I do not know, he put you in the first 10. Where did you put Nitish? I don't know where did you put him, and I put you in one of the best. That's okay.
Thank you for
and
this kind words.
the field which has been, advancement, lot of it, the thrombolysis has been going on, and with the intravenous, intraarterial, mechanical, and like that. I think we'll hear. We have already taken a lot of your time of the 10 minutes. Proceed on. Deepa.
Thank you, sir. So good evening, everybody. So today I've chosen this topic, thrombolysis in acute ischemic stroke. Although this topic may look very primitive because thrombolysis, intravenous thrombolysis with alteplase has been approved in 1996. even now, but it is the most underutilized treatment option for the stroke because of the lack of awareness among the public as well as the medical fraternity. It is the most underutilized tool, and use of thrombolysis can add to significant benefit to many of the lives who patients with stroke. So this is the table of contents I would be discussing on. So as you all know, stroke is a neurological impairment caused by a disruption of blood supply to any region of the brain. So as we all know, we have two types of stroke. One is hemorrhagic stroke and ischemic stroke. So we are talking mainly about ischemic stroke in this presentation. So coming to the stroke burden in India, if you see this slide, so approximately 1.8 million people suffer brain stroke in India, and stroke is the second most common cause of death in India. And these numbers are alarmingly increasing, and more number of young patients of stroke we are seeing very often. And there is lack of awareness among stroke among the general public. If you see the studies, you can see less than 1 in 4 Indians are aware of brain stroke symptoms, and most of them do not even know that there's a treatment options for stroke, and most of the time they end up going to alternative medicines, and they do not have the concept of time is brain, which I'll be discussing in the next few slides. So this is the lack of awareness of stroke, although it is a very primitive topic. So why do we require to identify stroke fast? So time is brain. So as you can see this table, so every second after a stroke, there are about 32 million neurons, 32,000 neurons lost, and per stroke, about 1.2 billion neurons lost, which adds to a significant stroke disability in terms of disability as well as the quality of life to the patients. And accelerated aging in terms of loss of jobs, loss of functional ability, as well as economic burden to the family members of the patients who suffer stroke. So what is the concept of thrombolysis? So what are we going to achieve by thrombolysis? So if you can see this first picture, so after there's a blood supply is cut off to the area of the brain, so there is an area which is called the core where the neurons are dead. That is, this you cannot salvage. Beyond this, there is a significant area which is called the penumbra, which is still salvageable by reperfusion therapies in the form of intravenous thrombolysis or endovascular treatments. So this is one without treatment with intravenous thrombolysis. You can see with time, so the whole of the area will get infarcted, and this adds to significant neurological disability. And with reperfusion, we are able to salvage the area with reperfusion therapies. So this is a common tool we use in our stroke management. This is just to indicate the severity of stroke. From 0 is the minimum with no stroke symptoms, and 21 to 42 indicates severe stroke. And the most area we are interested is this moderate strokes which have good outcome with intravenous thrombolysis. So what do you do? So first, any patient with stroke, we have to identify if it is an hemorrhagic stroke or ischemic stroke, and we have to identify the window, that is time of onset of symptoms and to the presentation to our emergency department. So if onset of symptoms is below 4.5 years, and these are the candidates for intravenous thrombolysis. So first thing is they undergo a CT head, and if they have a ischemic stroke, and these are the candidates for intravenous thrombolysis. And those beyond 4.5 hours and up to 24 hours with recent advances, these are also the patients for endovascular management techniques. So this will be spoken by the next speaker, Dr. Ambuj, in the next presentation. So this window is very important for best outcome. So what are the treatment options available? So as we all know, alteplase was a drug which was approved and even now used till today, that is intravenous RTPA, that is recombinant tissue plasminogen activator. It has been approved worldwide, but of late we are coming up with tenecteplase, which has a better advantage over alteplase in terms of that administration as well as the outcomes. It is comparable to alteplase and it has ease of administration. So it is very much used of late, and it has been approved by the European Stroke Organization. Expedited approval has been done by European Stroke Organization. And for those patients who present beyond 4.5 hours, or also those patients with large vessel occlusion, that is in terms of like proximal MCA, middle cerebral artery, or the ICA, thrombolysis itself may not be enough to completely recanalize the vessels. So in such patients, we require endovascular techniques, that is mechanical thrombectomy, to completely recanalize the vessel. So what do we do? So first is we administer the thrombolytic agent and then shift the patient for endovascular management without wasting time in between. So this is called as bridge therapy, which is a significant benefit. So bridge therapy is very useful. So what is the advantage of tenecteplase over alteplase? One thing, if you see this, there's fibrin specificity is better with tenecteplase. And when it comes to administration of the dose, so if you see alteplase, which is the dose 0.9 milligram per kg, the usual dose required, in this the 10% has to be given as bolus and the rest 60 minutes have to be given as infusion, and during which time you require significant monitoring. Whereas tenecteplase, it is given as a single dose, which is a significant advantage. Even in the CT room itself, when you see that there's an ischemic stroke, you can administer, and you don't require significant monitoring compared to alteplase. In terms of efficacy, it has non-inferior to alteplase, and also it has been, recent studies have shown that in large vessel occlusions, it is in fact has better than alteplase in terms of recanalization. So this is a drip and ship thing wherein, so if a patient with stroke is identified and you don't have a stroke ready center, so what do we do? So basically there is no availability of endovascular management. So we do give intravenous thrombolysis and then shift the patient to a stroke ready hospital where advanced endovascular techniques are available, especially those with large vessel occlusions. And so in between we are not wasting time, and then we are shifting the patient to the advanced centers. So in drip and ship, what we do, that is with alteplase, give the drug and then prepare the patient for endovascular management. Here with tenecteplase, it is give and go. Give the bolus dose and then you can plan further management. So time is very important. Time is brain, as I said. And what is the importance of time? Because as I told you, every moment several neurons are lost. So this is the benchmark time which has been given by ACLS as well as NIH, wherein this is the time you should, from the time the patient enters the emergency to the administration of the drug. So it should be less than 60 minutes to achieve best outcomes. In fact, a lot of these time can be saved with telemedicine, and with advent of telemedicine, a lot of this time also can be saved, and many of my colleagues have been able to achieve a door to needle time of up 10 minutes or less. So that is a significant time, because lesser the time, better the outcome, because there's a misconception that there's 4.5 hour window, so we have time till 4.5 hour to administer drug. That is not right. So the earlier you administer, better is the outcome of stroke. So this is for the tenecteplase. European Stroke Organization expedited use of tenecteplase in treatment of stroke. And as I told you, door to needle time is what is more important. That is the moment the patient enters the emergency to the administration of the intravenous thrombolytic agent. Less the door to needle time, so better is the stroke outcome. So what is this mobile stroke units? So most of the time patients are not able to reach the stroke ready centers due to various reasons. So in these patients, the concept of mobile stroke unit has come, wherein there is a mobile van with a CT scanner and telemedicine opportunities and a pre-hospital stroke team who will administer the drug in the mobile stroke unit. In fact, in India, 2 places I know have been using this. In 2017, In Coimbatore, Kowai Medical Center has introduced this. And in 2021, Assam Medical College have this mobile stroke unit where did the first intravenous thrombolysis in the mobile van itself. So this is one case to explain the use of thrombolysis. So this is our own experience in our center, wherein a 65-year-old gentleman presented to the ER with aphasia and right hemiplegia. His CT brain was normal. CT angiogram showed proximal distal MCA occlusion, left M1 occlusion, and he was given thrombolysis with tenecteplase and shifted to DSA for possible mechanical thrombectomy. But however, if you can see this next slide, so with thrombolysis itself, the MCA had opened up, and initial NIHSS was 18, that is a significant disability. But post-thrombolysis, we could achieve NIHS of 3. At the time of admission, he had globally aphasic and right hemiplegic. And at the time of discharge, he has minimal word-finding difficulties, hardly any limb weakness. He had only a drift in upper and lower limb. So that is the use of thrombolysis in stroke, and that is very important for us to be aware of this and spread the awareness about stroke management. And also, the mobile stroke units are definitely will be of more use because there are many factors which will prevent the patient reaching the hospitals and receiving the treatment at the proper time. So I complete my discussion with this. Thank you. So time is brief, so every minute counts. Be fast and act fast. Thank you so much.
Any question or comments from the house?
Yes, sir.
Mic उनको दिलो. हाँ, mic.
In established stroke,
yes,
the role of the aspirin and clopidogrel.
Yes, sir.
Because now still we are not using tenecteplase and alteplase in our hospital.
Okay.
So is it would we attend to add tenecteplase or alteplase? We are using still aspirin and clopidogrel
Yes,
to
sir.
prevent stroke.
Yes, sir. So we are
what is
still
your-
using.
What is your message, madam, to us?
Message is that everyone should be aware that stroke is still a treatable, very much treatable, and if the patient can reach the hospital or stroke-ready hospital within that time period, the amount of disability that happens with stroke can be prevented. So although it is not accessible to many of the patients because of many reasons, but probably with more mobile stroke units, this can be achieved in future. That's what we expect, sir.
Yeah, I think, yeah.
आपने सवाल उनसे पूछा है, आपकी अनुमति से हम I will seek your permission to answer that question.
Sure, sir. Thank you.
एस्पिरिन, क्लोपिडोग्रेल इस टाइप का जितना एंटीप्लेटलेट दवाई है, इसका प्रिवेंटेटिव रोल ही डिबेटेबल है, और खासकर थेराप्यूटिक रोल तो कुछ भी नहीं है. पेशेंट को क्लॉट है, पेशेंट को आपको जो भी लोकल यूसेज का थ्रोम्बोलाइटिक ड्रग है वो देना जरूरी है. जितना डिले हो रहा है उतना उसका प्रोग्नोसिस खराब हो रहा है. एक लाइन में.
Yes, sir.
That is the question. Yeah. Antiplatelet preventative कोई argument है. Sorry.
Yes, sir.
No, I think, okay, let me elaborate slightly. There are different issues in the management of a stroke patient. Prevention and, as you rightly said, the treatment from angle. Basically, prevention is not much to do with the attack what you are facing, handling. It's basically for preventing subsequent ones, and there we have the primary prevention and the secondary prevention, and then the term which is used is a tertiary prevention, which is not really, in my mind, a real prevention. So primary is before it has occurred. The role of the antiplatelet drugs in primary prevention is strongly debatable and not recommended. I hope that's the first message. Second message is that secondary prevention, yes, possibly it does reduce the risk of the subsequent stroke with some minor problems here and there, but yes, there it looks like that antiplatelet drugs are helpful. Now the question is that given attack which you are supposed to treat, there usually it has a very limited role, and possibly particularly in the first 4.5 hours or so, the treatment of choice is thrombolytic therapy and the thrombolytic therapy. To say that we do not have is not the answer. Now we are possibly the 5th largest economy in the world, and now we cannot say that we do not have the resources. Possibly the time has gone when we will say that we do not have the resources. Even government of Bihar has a budget of more than 2 lakh crores. The central government collects more than 70 to 80 lakh crores of the tax, and same is by the equal amount by the state governments. So possibly at every district level, you ought to have a thrombolytic therapy center, possibly a neuro center, and move in that direction. Possibly we do not have, no. I think the message is we should spread, and every district hospital should have the facility for the treatment.
We'll move to the...
Thank you, sir.
Thank you. So can we take one Dr. Ambu's lecture? After that, we'll continue the discussion.
Deepa, excellent job.
Yes.
Very well, very well.
Should I rate you better than it is?
घर में झगड़ा करवाना है क्या सर? मैंने बड़े रिक्वेस्ट करके डॉक्टर नीतीश को बुलाया for this session.
Well, thanks Dr. Deepa. Let's widen our horizon from medicines to neurointervention, and let me call Dr. Ambuj Kumar, who is a neurointerventional neurosurgeon, and his topic is neurointervention in stroke. Dr. Ambuj, please.
जी किससे नेक्स्ट होगा ये ठीक है ठीक भेज दीजिएगा मुझे मैं
Good evening, all of you.
I am happy to introduce Dr. Ambuj Kumar for this session. He is a consultant interventional neurosurgeon at Medanta Super Speciality Hospital, Patna. He had done his MBBS and MS from Jabalpur. He did his MCH from AIMS New Delhi and cerebrovascular and endovascular fellowship from Fujita Health University, Nagoya, Japan. He specializes in endoscopic brain surgery and minimally invasive spine surgery, aneurysm clipping and coiling, thrombectomy for acute ischemic stroke and complex brain and spine tumor surgeries. He is one of the few dual trained neurosurgeons, endovascular plus surgery, that is we call nowadays hybrid neurosurgeon, in India for the management of neurovascular diseases such as aneurysms, fistulas, etc. Dr. Kumar has written chapters to numerous neurosurgical textbooks and has published papers in major Indian and international publications. I welcome Dr. Ambuj to deliver his...
Thank you, sir. Thank you very much for kind introduction. Good evening, all of you. My topic for today's presentation is role of neurointervention in acute ischemic stroke. I will be talking in short about evidences in favor of mechanical thrombectomy for acute ischemic stroke. I will be talking about radiological workup in acute stroke patients, indications for mechanical thrombectomy, and at last I will discuss one case in which mechanical thrombectomy had been done successfully. So, role of mechanical thrombectomy was established in year 2015 for acute ischemic stroke when results of multiple trials, MR Clean, Revascate, SCAPE, SWIFT Prime, Extend 1A were published, and all of them strongly supported the role of mechanical thrombectomy for patients with large vessel occlusion. Later on in year 2018, Dawn trial and Diffuse 3 trial results were published, and they further extended the time window from 6 hours to up to 24 hours. And based on all these studies, American Stroke Association guidelines were revised in 2018, and they strongly recommended mechanical thrombectomy as the gold standard treatment, especially in appropriately selected patients with large vessel occlusion. So, jumping to the radiological workup now, the goal of acute stroke imaging is to see the 4P, parenchyma, pipes, perfusion and penumbra. Parenchyma to assess early sign of acute stroke as well as to rule out any hemorrhage. Pipes indicate vessels. We have to see the neck vessels as well as intracranial vessels to rule out any intravascular thrombus. Perfusion parameters to be assessed are cerebral blood volume, cerebral blood flow and mean transit time. And penumbra, which is the most important thing as discussed in the previous talk, which is tissue at risk of dying if ischemia continues without recanalization of the intravascular thrombus. This is the sequence of event which happens actually. There is a small core initially of dead tissue, and surrounding that small core there is a large area which is salvageable, which is known as penumbra. And if we leave this as such, the small core gradually increases in size and the penumbra, we lose the penumbra with time. So all the target of intervention or thrombolysis, anything is at the penumbra. Coming to the imaging modality, NCCT head is the most widely available and accepted imaging modality for stroke patients. It can be done quickly. It not only helps to identify hemorrhage, but it can also help detect early stage of acute ischemia by depicting features such as hyperdense vessel sign, obscuration of lentiform nucleus, insular ribbon sign, and hypoattenuating brain tissue sulcal effacement. Apart from that, additional study in form of CT angiography to see for large vessel occlusion and CT perfusion study can be added in this. Apart from all these, there is an objective measurement, objective parameter, objective score to assess quantify the amount of ischemic tissue in form of CT aspect score. And in this CT aspect score, we design 10 areas, 1 to 10, and each area is given 1 point. So the total score is 10, and for hypodensity in one area, 1 point is diminished from the total score of 10. So, for example, there is hypodensity in 2 areas, this total aspect score will be 8. And the areas are internal capsule, caudate, putamen, insular ribbon, and M1, M2, and M3 in form of frontal opercula, anterior temporal lobe, posterior temporal lobe, and in superior cut, M4, M5, and M6. So on basis of these things, a CT aspect score is calculated. Coming to the role of MRI, MRI is undoubtedly better in terms of sensitivity and specificity. However, because of lack of widespread availability, more time consumption, and lack of trained technician, especially in emergency period, the role of MRI in acute ischemic stroke is limited to posterior circulation stroke, stroke beyond 6 hours to look at infarct volume, and cases of wake-up stroke in which we don't know the exact time of onset. Now coming to the indications of mechanical thrombectomy within 6 hours, the age of the patient should be more than 18 years, NIHSS score should be more than 6, CT aspect score should be more than 6, and there has to be large vessel occlusion in form of M1 or ICA occlusion, and pre-stroke MRS score should be 0 to 1. Coming to the indications beyond 6 hours, the indications are more or less same. The only difference is that we have to know the exact infarct core volume, and for that we need to do MRI done with MR diffusion studies. And in this MR study, the core volume should be less than 31 cc in patients with age less than 80 years and less than 21 cc for age more than 80 years. Apart from that, rest of the things are more or less same. These these indications were added after the DAWN and DIFFUSE 3 trial. So, just to show the importance of this procedure, there is a term called NNT in epidemiology, that is number needed to treat. This is effectiveness. This indicates the effectiveness of any medical or surgical intervention, and lesser the NNT, greater is the effectiveness of that therapy. So, in this table, if you see the value of NNT is 2.6 and 3 for acute stroke intervention within 6 hours and beyond 6 hours even. The only thing which has got lesser NNT value is rapid defibrillation for cardiac arrest. All other things have got higher NNT. So this shows how effective and how miraculous this procedure is. So before finishing my talk, I will just show one case example. A young female presented to us with right hemiparesis and facial weakness and aphasia. Time onset was 7 hours back. CT scan was done urgently, and this CT scan showed left side basal ganglia hypodensity, and on the basis of this CT scan, aspect score was around 7 to 8. And CT angiography was also done, image is not there, and that showed M1 occlusion. So based on these findings, patient was immediately shifted to DSA room and DSA was done. On the image on left hand side, you see there is sudden cutoff in left M1, and simple aspiration technique using penumbra pump was used for this patient. And on the right side image, you can very well see the TK3 recanalization was achieved and all the MCA territory was filling very good. This was the clot fragments which were extracted from the M1 vessel, and the clinical result were also very good. This was the CT scan after 16 hours. There was very minimal increase in the size of infarct core. Apart from that, there was no new onset of any hypodensity. Post-procedure patient sensorium improved with improvement of aphasia on table only, and power at discharge was 4+/5 on left side, and discharge MRS was 2. So this was a very gratifying result. Thank you so much. Thank you.
So nice presentation, sir.
Thank you, sir.
And it was a good thing to see all these intervention happening in our place, because we know with a stroke, which what we were doing before was just preventing the recurrence of a stroke, not the treating the acute stroke. As sir also asked the same question, we are giving ecoaspirin and clopidogrel to the acute ischemic patient. Is it justifiable? So it is justifiable to prevent the secondary stroke, but the acute stroke, the only treatment is thrombolysis and the intervention. And we have seen the picture also how that thrombolysis was done, and NHS score was from 18 to 3 it reached, and after that your MRS scale was only 2 for the discharge. So these intervention will help all the patients of this area, because everybody knows that now the risk factors are increasing. Who gets a stroke in our house also, we don't know. So in this with this intervention, I think people will be very helpful for all the interventions which we going on. Yes, sir.
Nice presentation. What do you do for the peripheral arterial blocks, not M1 or IC artery?
No, sir,
do for M2
for
and
distal, for initial part of M2, I had tried in some cases. I will say 30-40% of the cases I got success, but definitely it is more difficult to recanalize and get successful results in those cases. And for further beyond that, there is no role of mechanical thrombectomy.
For distal arteries, the smaller arterioles, there is the result is same, whether you do the thrombectomy or you do the medical treatment.
Yes, sir.
But for M2 and
M1 ICA,
M1 it's okay.
Yes.
M1
ICA, early part of M2 it can be tried, but the results are still dicey, not very good.
And yes, no, medical management is always there as a secondary prevention. And mind you, only 20% of the patients on aspirin or clopidogrel, they get benefit from not developing a second stroke. 80% of the patients have a still high risk of getting a stroke.
Sorry to interrupt, for that reason, peripheral vessel flow, thrombolysis को फायदा नहीं है, वहाँ पर तो already disease has been happening for 20 years. That is what you are picking up on the angio.
No, it is all for a carotid thrombus which has dislodged and lodged into the peripheral vessel. Then what do you do? That is the main idea. So the combination of antiplatelets is only for secondary prevention, not for primary treatment. Primary treatment is this one.
Sometimes in some cases what happens, sir, like there is a blockade in M1, you open it up and later on you will find that distally there is a very small fragment which is causing an area of hypoperfusion. In that cases, what you can do, you can take a micro catheter up to that place, and thrombolytic agent can be given directly over there. Like we do thrombolysis, IV thrombolysis, intra-arterial thrombolysis can be attempted in those cases. Yes. Right. Sometimes even after thrombolysis, what happens, large vessel occlusion is there, you give IV thrombolysis, clot disintegrates and get dislodged in distal parts. So that can be tried, but the results are not very as good as in the cases of M1 and ICA.
Okay. Any other questions, queries? from the audience. Any questions, queries?
Thank you.
I think wonderful job.
Thank you.
And but only thing I was wondering, you showed us, Ambuj,
Yes, sir.
the CT scan pre and post to say that the penumbra has
Sir, just
not
1
got.
minute, sir, is asking.
Yeah.
What is the vital time of the neurons?
Yes, sir.
Neurons, the death of the neuron,
Yes, sir.
how it will take time after stroke?
So in the last talk, Deepa was showed in every minute how the neurons keep on dying. Millions of neurons are dying for every minute loss. So I don't remember the exact
So-
figure, but we all know we need not to waste a single minute.
So,
How many neurons Deepa ma'am can tell you?
what is the viable time after stroke?
No, no, sir. Thrombolitis.
I think Deepa, can you give the mic to Deepa? I think.
After disruption of the neurons, when stroke take place, then there is a complete disruption of the neuron due to loss of the blood. So can it revive?
So disruption of neurons.
Sir, see, with every stroke, so every second, 32,000 neurons are lost. With time, definitely the number increases. The amount of neurons which are lost increases, and this adds to significant neurological disability. So what we are achieving is, we are preventing this by identifying the penumbra, that is a core, but that is a salvageable tissue, by reperfusion therapies in the form of intravenous thrombolysis and mechanical thrombectomy. So we are perfusing those areas which are salvageable. So that is a time window for intravenous thrombolysis is 4.5 hours, and for mechanical thrombectomy endovascular procedures, earlier it was 6 hours. With recent DAWN trial and DIFFUSE trial, it is extended up to 24 hours with advanced imaging techniques like perfusion study, where you still identify the area which can be salvaged and do a mechanical thrombectomy, endovascular procedure.
So purpose is only to save
Sorry
the
to interrupt you, sir.
I think,
sorry to interrupt you, sir.
Okay, I think should I?
Sir, sorry to interrupt you, sir.
main purpose to save the
Sir,
neuron.
sir, you can talk to her by the sidelines, and let's.
No, I think.
Yeah.
Let me clarify. There are two different things which tend to get confused. One is situation where the blood supply of the whole brain is stopped, like in no. I think there are two situations that are not comparable but confused. One is when the blood supply of the whole brain gets stopped, like in cardiac arrest. The brain is not able to sustain beyond few minutes. You can say 3 minutes, arguably, but beyond that it gets damaged. The another situation is where blood supply of a particular portion of the brain is affected, and it's affected differentially. That means certain areas are affected more, certain areas are affected less, and certain areas are not affected. So this situation is not comparable to the one where with the cardiac arrest. And it is in this situation where we know that there is a core area which did not get sustainable amount of blood. That means a dead area. So we have a core dead area. And then you have a stunned area where they are just getting enough blood to survive but not to function. And then there are areas outside which are surviving and functional. And what we call the area which is surviving but non-functional is the penumbra. I think let us say that is what we use the term penumbra. And it's not only not getting blood supply. The metabolism of the brain is aerobic and anaerobic. When there is not enough oxygen, it shifts from the aerobic metabolism to the anaerobic, and not only the blood amount, that cascade of the ischemic cascade leads to the generation of the toxins, and because of which the area which is a stunned area surviving but stunned, non-functioning, it slowly becomes dead. And the purpose is the area which is surviving but stunned, non-functioning is the one where you improve the blood supply. So they shift back from the anaerobic metabolism to the aerobic quickly, and further damage is not done. So all this thrombolysis is to make a blood supply to the area which is surviving but non-functional, to make them functional. And it has been proved that over a period of time, which possibly appears highly variable, to say 24 hours like that, no, it varies from individual to individual, and that is the reason some of the research works are now going, that do not be within the limits of the time. See at the functional imaging, and if there is a functional imaging, there is a mismatch between diffusion, perfusion and the functioning, then you still go for it beyond that hours. These are the 4.5 hours is an average, but in individual case, that if you demonstrate it and the trials are going on, maybe there was some time back it was 3 hours, it became 4.5 hours, and maybe after 5 or 10 years we hear, then a smaller subset you can go, it's possibly imaging based individual treatment. Still the recommendations have not come. So the basic concept we need to understand that we try to salvage area which is surviving but non-functional. I hope that. Okay, thank you. I think.
Thanks, sir. Before we call it a day, let me invite previous speaker, Mukund Prasad sir and Dr. Deepa Ane, and I would request Professor A.K. Agrawal sir to hand them a token of appreciation, and I would also like to invite Dr. Ajay Sinha sir on the dais to share our token of appreciation with the esteemed chairpersons and also the vote of thanks. Thank you.
Part was neurology because the best part was neurology. Why? Because it gave a lot of basic sciences. जो आपने बताया, anaerobic, aerobic, and all sort of things. चलो ये तो बताया.
सर को सुनने के लिए पहला सेशन रखना पड़ेगा. तो एक्सटेंडेड पीरियड तक सुन पाएंगे सर को. आपको सुनने के लिए सर फुल सेशन बनाना पड़ेगा हम लोगों को विद द कॉफी. मेरे लिए तो बहुत लर्निंग रहती है सर से. जब भी फोन पे बात करना है तो कुछ न कुछ लर्न किए बिना फोन नीचे नहीं जाता लगता है. आइए ना सर प्लीज सर.